That's so good.
Yes.
Okay. All right. Gosh. So welcome everyone. We just love doing this presentation, whether it be face-to-face or even just talking about it. And so if there's anything that's unclear, just stop us. And this is the whole purpose. It's a discussion. We're not talking at you. This is a discussion. Typical learning objectives, just to help you to apply the knowledge that you've gained throughout the course and to sort of bring it together with real life scenarios.
And Leslie, do you mind if I say one quick thing?
Jump in anytime.
Leslie is very careful of including here is that idea of care for a deteriorating patient. What we know is that it's critical that we don't enter the shift with sort of a transfer of accountability and an idea from what I got in report about what, how my day is going to unfold. And we sort of, we need to focus on that, I think, a little bit more, because often we ask students to prepare for the day, and they prepare for a typical day with a typical patient, let's say, experiencing, I don't know, some kind of medical condition or surgical procedure. But patients are not typical. And so when we prepare for the typical, that's so that I've got that bracketed area filled in, and now everything else is open to me, and care of the deteriorating patient is so important, right? It's particularly important now as we look at the complexity of care.
Yes, absolutely. And as I say, isn't that what we all signed up for? No 2 days are alike. And so you cannot go with that plan of what a typical day will look like. And I do always remind everyone, especially in adult health challenges, is that you want to plan for the unexpected. So get your work done as quickly as you can, because you don't know when you're going to have a cardiac arrest. So we're going to start with our case. This is Chris Saxton. She's a 56-year-old female who's presenting with a short history of chest pain, described as a bit like indigestion, accompanied by shortness of breath, nausea, and diaphoresis. She does have a past health of hypertension, for which she's treated with metoprolol 25 milligrams BID, and she has no allergies. So she's presenting into the triage area of the emerge, and Sue, you can help me set up that context. This patient has arrived with chest pain.
Okay, and so I'm going to ask you guys to jump in. You don't know emergency. I don't know if any of you have had that for your placement just now, but so Chris is going to come in at the same time as a lot of other patients, right? So I've got people who are coming in with nausea and vomiting. I've got people who are coming in with, let's say, you know, they've turned their ankle, or they may have a laceration. Somebody might have a nosebleed. Somebody might have acute abdominal pain. I've got a whole bunch of things. How do I know who is the priority of those patients? How would I know? So I've got a lineup in front of me.
They go through triage. They would go through triage, and then that system would assess their priority.
Right. And so the essential role of triage is a rapid, evidence-based assessment that enables you to prioritize, not to make a medical diagnosis. Does anyone think from these symptoms you could make a medical diagnosis? No, but we definitely could determine prioritization. What is the level of risk? And you can't always be accurate. So I think there's always the risk that you think someone is like indigestion or abdominal pain, but they're actually a dissecting aneurysm, or that is not yet significant enough to see them crashing, or other things. But you do your very best. Now, in the past, we used to just literally have patients lined up in a line, standing in a line, and you could have easily 20 patients waiting to be triaged. And it could be incredibly stressful, because I know who's in front of me, but I don't know who is further down the line. So one of the things that we've moved to is having multiple triage nurses when you're busy. So not just one triage nurse taking that responsibility, and also having check-in systems, those self check-in systems, where the patient actually puts in at least a couple of words about why they're there. And that enables you to prioritize even who the triage nurse may see most quickly. So this patient, where would you put her?
Probably pretty high on the list.
Yeah, I'd call her right over. Call her right over, because until I know otherwise, everyone's an MI. Everyone with chest pain's an MI until I know better. Every adult. even 22-year-old, because there's lots of things that can play into that, drug use, medical conditions, other things. So absolutely, I'm going to call her right over, and we're going to do an assessment outside in that, at my triage desk. What else do I want to know?
Her vitals?
Yes, her vital signs, absolutely. Anything else?
What is short? Like how long exactly?
Yes, we don't have the exact details of that, do we? So when we say short, does that mean a couple of days? Or when we say short, does that mean 15 minutes? That's going to impact decisions we may make later, right? Depending on what's going on. What else? Are there any other assessments related to, she's given us some information that's a little vague.
What is the severity of her hypertension?
Yes, I absolutely. So what is your blood pressure normally, if you know, what does your blood pressure normally run at? And lots of patients know that, don't they? How about pain? Would we ask for more details about that? And we know that we do a typical pain assessment. Does that take a lot of time?
No.
I can collect information very quickly, and it doesn't mean someone else isn't going to collect that information, but that does enable me to make some determinations about where that patient may go within the emergency department in terms of level of priority. Any thoughts from you, Leslie?
Yes, I was going to say, just if I can twig everybody's memory, for those of you who've taken adult health challenges, you recall that we did pain assessments with using a systematic approach, using PQRST format. And again, this is a great example to use that systematic approach to symptom analysis. Okay, and so you're correct. We do need to do our assessments. We need to look at our subjective assessment. We always do a subjective before our objective assessment. And so this pain started when she was vacuuming, pressure, tight pain that's radiating to her throat. She's never had it before. She is a remote smoker, 15 pack years history of smoking, and she quit 5 years ago. The objective findings are that she is quite diaphoretic, complaining of nausea. As you can see, her vital signs, her blood pressure is 110/70, her heart rate is 90, stats are 98%, respiratory rate's 20. Her chest is clear, although her skin's a bit cold and clammy. I'm getting strong pulses. So her peripheral pulses are strong. So what is your concern based on these findings? Or maybe you're not concerned.
Her respirations are high and her blood pressure is fairly low considering she has a history of hypertension.
Okay, so that's a really good point. So what is the normal respiratory rate?
15 to 20, but
So
12 to 20, but 20 is on the high side. It's borderline.
Sure, and so that, and again, somebody who might be just walked in from the parking lot might have a respiratory rate of 20, but good to keep eyes on that sort of thing as well. Very good. Her blood pressure, it may have dropped, although we don't know what her normal is, but I think that's a really good detail to be focusing on, is what is her normal blood pressure. We always look at trends. So maybe 110/70 is low. However, all things being equal, that would give me some comfort knowing that she has a pressure that's actually adequately perfusing. Any other concerns that you might have?
Potentially dehydration just due to the diaphoresis and the nausea.
Okay,
but
good.
then she does have strong pulses, so not entirely sure.
But again, those are all the cues that you want to be assessing for. So you're worried that she's got cool skin, cold and clammy, which is concerning, although inadequate pressure and evidence of distal perfusion. So again, just putting it all in context, she is complaining of chest pain. or that pressure. Remember that women present a little bit differently. They don't articulate that elephant sitting on their chest like men do. So that pressure is of concern. And remember that we always assume any chest pain is myocardial ischemia until otherwise proven. And so what are some of the evidences that you need to sort of anticipate to determine whether this is a myocardial infarction or something else? What are the ways that a myocardial infarction is actually identified?
Hook her up to a 12-lead EKG and get some blood work done.
Absolutely. And what blood work would you anticipate?
Troponin.
Exactly. And while you're drawing your troponins, you would do just standard routine blood for electrolytes, urea creatinine, and a CBC. Okay. And so some of the potential problems, and so you've sort of alluded. Yes.
I'm just so sorry. There was just a little bit going on here. Can I just jump in and tell you what my emergency mind would be thinking of on that past slide? Would you mind going back just for 1 second?
No, of course.
And again, all of us are going to develop our own process, right? So here's, you know how I've told you, you're all going to develop your style. My style is, what do you throw into the fine pile and what doesn't go in the fine pile? And even if they're in the fine pile, they can always come out, right? So many of you noted vital signs, mostly fine. Okay, fine. That means I don't have to remember every detail of it. It's mostly fine. Chest clear, fine. But I've got a lot of things that aren't fine, or no previous episodes. Okay, that's relative. I'm going to keep it circulating. There are things that tell me it starts to form a clinical picture, never a medical diagnosis. It is beyond our regulatory scope to make or communicate a medical diagnosis. But that doesn't mean I don't see a clinical picture. All right. So the story is unfolding just like reading a novel. And you know how in a mystery novel, they give you clues? The clues start to lead you towards something. She's giving us clues. Her body is giving us clues. So pain began with activity. That's a clue for me. Now, also when somebody has chest pain that began at rest, that's a clue for something else. But her pain began with vacuuming. For all of the students here who do housework, I just am liberated from housework. But for all of you who do housework, vacuuming is a killer. Leslie, can you attest to that? Vacuum
Oh my gosh.
Is a killer. Whenever you have anyone C-section patients, do you tell them no vacuuming for 6 weeks? I like to tell them no vacuuming for the rest of your life. But so vacuuming is actually a very physical activity. So pain began with vacuuming. I'm thinking, aha, right? That's pain with activity. That pressure in her chest radiating to her throat. That's quite an important indicator. It tells me that there may be, like, again, that doesn't go in the fine pile, that goes in the alert. I've got some alerts coming up to me. Smoker, alert. Diaphoretic and nausea, alert, in particular with pain, chest pain, diaphoresis, nausea. That's a clinical picture, right? Clinical picture that's starting to form. There she's got that skin, cool, clammy. She's got good pulses. Do you see how it starts to form a clinical picture for me? And that's so critical that I've got some things that are fine. Clinical picture, but I would say at this moment, stable. Do you see how I'd say stable clinical picture is forming? I need to get more information stacked. That tells me this clinical picture, I'm not making a medical diagnosis, but where it leads me is stacked. Does that make sense? It leads me to a determination that this patient goes to the resuscitation room where she needs a secondary assessment within 5 minutes. That means that the next nurse sees her within 5 minutes. Does that make sense? And would you all agree with that? Yep. Because remember, the body buys us time and we never want to throw away that time. Okay, on you go. So I'm so sorry to. But
no, please do. But and this is where, when you talk about that clinical picture, what other clinical pictures might this be presenting? What other clinical pictures could this also be?
And remember, we don't jump to assumptions, right? There's lots of things that could be going on. There's not the biggest risk And we talked about this in thinking biases. Remember, we get that tunnel vision. So I start saying, oh, it's an MI. And then I don't let myself have that broad perspective that it could be something else. And we make all the evidence fit the MI picture instead of letting all the evidence speak for itself. And that can be so risky. Remember, we make that mistake, and it's kind of human nature to let the evidence fall where you want it to instead of letting it speak for itself. So let's just all jump in. Can anybody think, oh, we've got a chat here. Let's see if there's anything there.
Clamminess and cool could indicate a sugar level disruption.
Yep, that cold and clammy, absolutely blood sugar. A panic attack. Molly says a panic attack.
No.
Okay.
Yeah. I think it's an interesting thought for sure. You would always keep that in the back of your mind. We always treat, think like with the severity of the symptoms, we take the symptoms at their severity, but we'd always be keeping that open mind. What else could it be? Emma says hernia, particularly like a hiatal hernia, where you can have that reflux, and that reflux can be quite painful. So absolutely. Oh, gallbladder attack. Yes, absolutely. So that gallbladder attack can be diffuse. We typically talk about right upper quadrant pain, but sometimes it's hard for all of us to localize pain. And you can have that right upper quadrant that can be more central. The nausea, the vomiting, diaphoresis can accompany pain, regardless of where that pain is, right? Yeah, Emma says ulcer. Yeah, acute ulcer, in particular, a perforating ulcer, although we might see different vital signs with that, but ulcer for sure.
And think about this pain that's in the sort of up in the thorax region. Does that help you to give some other cues or clues as to what other further assessments you might need to make?
Thyroid related?
Pardon?
Could it be thyroid related?
Thyroid.
It's an interesting thought.
Yeah.
The reason, and Jen, that's a very interesting thought. The reason I might put that as less likely than more likely, I never rule anything out, is that her heart rate was normal, and thyroid often has a real impact on your heart rate, either speeding it up or maybe slowing it down. But that's an interesting thought, and I would keep that in the circulating.
So she's having this sort of mid-epigastric kind of discomfort. We're looking at perhaps it being some kind of GI or GERD type hiatal hernia. What other conditions might it be related to the thorax?
So think of physiology. What's under there? What other kinds of things?
I think of musculoskeletal issues like a trigger point in your pec or in an intercostal can recreate all that.
So important. Brilliant. Leslie, do you want to talk about that?
Yes. And so one of the conditions that you might see is costochondritis. That is a very painful condition of inflammation between the intercostals. And it carries on for about a month's time. You have to be on NSAIDs to help reduce that pain. Very, very painful. So you're thinking about costochondritis. Is there anything else that might be even a little bit deeper than the rib cage that you might consider as a potential cause for this discomfort, and you need to do further investigations?
I feel like you're hinting at lungs, but I'm trying to figure out what condition it would be.
Yes, for sure. And so it could be a pneumothorax. Even pneumonia can be quite painful, but it could be a pneumothorax. It could be pericarditis. Very, very painful. And that pain would you just get the patient to sit up and move forward. And if the pain went away, that would be pericarditis. If it was costochondritis, it's that local inflammation, that muscle in between the two ribs. They're so inflamed that you touch it and it's just excruciating. You don't get that with angina or myocardial infarction. Looking at the pulmonary embolism, what are their stats doing? Does it hurt to take a deep breath? And then, of course, with the aortic dissection, quite typical, you will have a complaint of like a ripping sensation. as opposed to that vague indigestion, but certainly you can. And then you would take a blood pressure in both arms and see if there was any change. The, very typical, and for me, I haven't seen an aortic dissection that really was compromised until they were practically dissected from stem to stern. Then I noticed about a 30-degree drop in the left arm from the right arm. So, but again, just rule of thumb is we would check a blood pressure in both the left and the right arm. Okay, and so we're thinking that this patient, we've ruled out blood pressure is equal in both arms. There's not that ripping sensation. We've had a chest x-ray done. So it's really not indicative. It's looking more like acute coronary syndrome. And we are having some ECG confirmation with that. And we'll talk about that in a moment. So what is the initial treatment for somebody with acute coronary syndrome?
Oh my.
Oh my, absolutely. Yes, you're absolutely right. You want to get oxygen on the patient. And as you saw from the initial slides, the stats were like 95%, not horribly bad, but get the oxygen on and then you don't have to worry about it until you do a secondary survey. So put on oxygen. Of course, they need to be monitored and you need to get your IVs in. So absolutely. The underlying focus will always be your ABCs. And so we're going to be assessing their airway, breathing, and circulation, just asking the patient to talk. You know the airway is patent. You're watching the respiratory rate. You've told me the respiratory rate's 20, so breathing is adequate. And you've told me the blood pressure is 110 on 70, so we've got adequate circulation and pulses are present. So very quickly, you're able to assess and sort of check off you've got stable ABCs. You've got your oh my. And at the same time that we're getting our ECG hooked up, we are doing a brief history and physical. And of course, the most, an early medication that's so important is aspirin. Baby aspirin is generally what they would give in the early phases in the emerge department or en route to the hospital. Baby aspirin that is chewed. Why do you think we chew it? Why would we have the patient chew it?
It's absorbed faster.
It is absorbed faster. We need that antiplatelet action very, very quickly.
Leslie, can I jump in for 1 second? I'm going to zip you back one slide.
Yeah.
What was I going to say? Okay, we're putting the patient on a monitor and we're setting up vital signs. So we're going to see our heart rate continuously, right? When they're on a monitor. But you get to set up a couple of parameters. We've got them on an O2 sat, so that's continuous. How often would you set that monitor up given this patient to take blood pressures? Because you have determination, the monitor is not going to make it for you.
Would 5 minutes be too long?
No, 5 minutes is fine. I'd say 5 to even 10 minutes might be okay because she's got 5, even up to 15 at this point. Till I have more, I don't have an ECG yet. I'm just setting it up because we've got a blood pressure that's very stable on arrival. I'm right with that patient, so I am going to be able to see changes. And do you remember blood pressure is a little bit of a later sign? So anywhere from 5 up to the outer limit, I might say 15, just so that it's not constantly like there's a lot happening for this patient right now. And you might think because she's stable, I might think I don't want to just overwhelm her with like a blood pressure every 2 minutes. If patient's unstable, I might be setting the machine up for every 2 minutes. But right now, I think that range. Leslie, would you make a different decision?
No, I think that's absolutely, the patient's, as you said, all indicators are stable at the moment, but you know that things are unfolding. So no longer than 15, but definitely as the patient becomes more unstable, I think Q5 minutes would be accurate. Okay, so the ECG has come back, and we don't expect you to actually diagnose a 12 lead, but looking at these T waves, which one would you think was suggestive of myocardial infarction? Which of these 4 presentations would you expect on the ECG that you have just completed?
And Shelley's given us an answer, and she says the one that we're looking at, the ST, right? Emma, same thing, ST elevation.
That's correct. That is correct. And so when you see that on the ECG, time is myocardium, and there is a real sense of urgency to get the team there to get the intervention.
And I'm going to repeat what Leslie just said, because those are words of wisdom. This is, you know, there's some things that you can look up. There's some things you carry right in the front of your brain. You're never going to forget this. Time is myocardium. There's never going to be a time in your career when you have a patient who is an active code that you see ST elevation, that you don't get someone there, whatever the cost, right? Whatever it takes. If I have to call the CEO of the hospital to get somebody there, I don't care. Time is myocardium.
And so as we see this on the ECG, what are the interventions that you're thinking may be appropriate for this patient? What are the interventions for someone who's experiencing acute ST elevation myocardial infarction or a code STEMI?
In sorry.
Yeah,
I
go
just
ahead.
wanted to jump in, and Leslie, code STEMI. Can you, for those who might not have taken adult health challenges, the Bridgers don't take that, code STEMI.
Okay, so code STEMI is when someone presents in the emergency department with an ECG that has the ST elevation, and they would call what they refer to as a code STEMI to have, because time is of such critical importance, we don't have that time. So we need to make sure all the players, all the team members are in place. And so when we call a code STEMI, that means that we need cardiology, we may need the cath lab, we may need the pharmacist. Whoever we need knows that there's a patient that needs an intervention within a very short time. Right. And it depends on what center you're working at, what that intervention would be. So let's say you're working at a community hospital in Campbellford. What treatment would be important? What treatment would you be anticipating for a STEMI?
So I recall from adult health, you had mentioned that morphine would be given, but I'm concerned if they need to be rushed right to surgery, that would affect anesthesia and all of that. But you had said, I think before, that not only managing pain, the morphine assists with assisting in blood flow.
Yes, and we're going to hang on to that thought. Thank you for that. We're going to talk about that in a moment. But urgently, we need to prepare this patient for an intervention, and I think Emma said a stent. Yes. So two options for this patient would be some kind of a thrombolytic, so an antithrombotic given to dissolve that clot. So an antithrombotic or a clot buster medication, a thrombolytic, or a trip to the cath lab for a stent placement. So remember that door to needle time, so the time the patient presents to the emergency department, gets that ECG done, the ST elevation is recognized, to the time the IV is in, the medication is mixed and administered is 30 minutes. Sue, did you find that ever a challenge to get that administered?
Every time.
Yeah.
Every time. You know, because think about it, it's door to needle, not the time I get them in the resuscitation room, because 30 minutes would be nice in the resuscitation room. And Leslie, if you remember, and I'm just going to, before I get there, STEMI, just everyone's got it, ST elevation MI, right? ST elevation MI. So I remember when it used to be an hour. Do you remember that, Leslie? Door to needle used to be an hour in the early days, and that we found stressful. They took away some of the requirements that slowed us down, right? So some of the extra requirements that slowed us down. But remember, a person is typically arriving with their clothes on. I need to get their clothes off. It can't be just like pulling them off. The patient is maybe distressed. I've got to get that monitor gone. I've got to get the ECG. I've got to get IV, and I've got to get bloods to the lab. I've got to do a rapid assessment. There's a whole bunch that's happening. So if I need help, I need help. A code STEMI, even before you're getting there, even if I'm suspecting an MI, if there's another nurse available to help me get all that en route, or on board, we're going to get some help. 30 minutes is really critical for patient outcome. Yes. Shelley, I want to talk about that. 30 minutes is really critical for patient outcomes, right? And that's why we set that target. We're not a failure if we don't make 30 minutes, because sometimes things interfere with that, right? Sometimes getting an 88-year-old person up onto the stretcher takes a little bit of time. I have to find a stool. I have to get, things can happen. but it is really critical that we are always aware of that. And we always have that clock ticking in our head. Tick, 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 tick. Time is muscle, right? Time is that myocardium. And Shelley said a really important thing. And this is, Leslie, we can talk about best practices. This is why we have moved to some better practices, because sometimes it can take a long time to even seem to get to the triage nurse, let alone other things. And that's why we have moved to better processes, because in the old days, in my early years of working in the ER, it could be literally somebody could be waiting in the waiting room for 40 minutes with chest pain, and I wouldn't know that they have chest pain. Their wife is patiently waiting in line while we've got a barrage of patients. And there wasn't a process to see who's coming in. That's why they've moved to those mechanisms where we can see right away what is the primary complaint, and then moving in. It's also why we tell patients, if there's any sign of chest pain, don't drive yourself in. Take an ambulance so that treatment can begin right in the back of that ambulance before you even get there. That delay is not helpful.
Absolutely, that's so important. And we are benchmarked across the country, so these stats are all recorded. So we know which hospitals in Canada do a great job of getting people in and getting the thrombolytics mixed up and administered. The other thing, so door to needle time is 30 minutes, door to balloon time is 90 minutes. Yeah. So if you work in a cardiac cath center like Centenary or Sunnybrook or the downtown hospitals, you can get the patients into the cath lab fairly quickly, but it's actually get them onto the table with the catheters in their groin and a balloon up into the infarcted area within 90 minutes. And again, that is a very tight timeline. It is very tight.
And Shelley asked us a good question. She asked, in a small place, you said Campbellford, would your goal then be that we're thinking medications as first line versus something else, because they're not going to have the resources like a cath lab, right?
Yes, exactly. And that's what the evidence supports, that you would give the thrombolytics first, especially in those areas. Sometimes if you're in places like, and I guess Lake Ridge, that they may give you the TNK as they are transferring you en route, so that there is no delay. Although they tend to not like to do cardiac caths on people that have already had the thrombolytics, but that is a rescue angioplasty. They'll do that. But yes, in Campbellford, door to needle time would be preferable. In a place like Sunnybrook, it is door to balloon time because they have those resources. Although I do have to say, Vancouver does an amazing job at transferring people around the city that are code STEMIs. They have such refined systems with ambulances and paramedics that are trained, etc., that they transfer people around the city all the time. We need to take lessons from them. So as you are doing your assessments for preparing for that door to needle time, you are also working up there the checklist. There's a checklist that you would be providing to the cardiology who's going to order it of any contraindications to thrombolytics. And generally the contraindications around anything neurological. So any kind of neurological malformation, what is it? What am I thinking of, Sue, when the arteries and the veins grow together in the brain? Maybe it's just AV malformation. So any kind of neurological problems, strokes, any kind of intracranial bleed, any kind of intracranial trauma, of course, any kind of active bleeding. So if they had a nosebleed, that would be a contraindication of thrombolytics. Now, I have done thrombolytics with somebody who they had a little bit of a nosebleed. Oh my gosh, they ended up with such a massive bleed. The cardiology made that decision to go ahead because it's far preferable to save somebody's heart. And we can certainly give them a unit of blood if they needed it, or we could stop the bleeding, the cautery of their nose. But this is a massive bleed once we gave the TNK. Of course, pregnancy and any active peptic ulcer would be contraindications. And there are relative contraindications. So for instance, CPR, if somebody has had coded at home and they had CPR en route by the paramedics, they would consider giving it. They would do the risk benefit and knowing that somebody who is trained in CPR administered CPR, that they would likely go ahead with it. But if it was some bystander on the street, they may not go ahead with thrombolytics. And also anybody who's has a non-compressible vascular puncture. So if somebody had undergone some kind of a procedure, maybe they had an arterial line or some other kind of X-ray, diagnostic X-ray in which the artery was punctured, then they would not be eligible for thrombolytics. So we do that quickly while we're doing our other workup with the patient. And always we are thinking about pump failure. And I know that we've talked about shock in high acuity. And Sue, is there anything you want to comment on around cardiogenic shock?
You know, I like to make this point. This is a really important point. Do you remember when we talked about the different kinds of shock, the categories of shock? Shock is fundamentally a lack of oxygen at the cellular level, but there's different mechanisms that lead to that. And that cardiogenic shock, if we treat all shock the same, if we had just one simple shock protocol, then in fact, the way we treat hypovolemic shock, if I were to apply that to a patient in cardiogenic shock, I actually exacerbate the problem. If I start pouring liters of fluid into a patient in cardiogenic shock, where the heart is not able to pump effectively, all I do is increase the demand on the heart. I increase the work of the heart that is already overworked and not functioning. So it's so important that we understand at this point, we are thinking, we're already in the process. This is fine decision-making, and we're thinking medications. That doesn't mean we may not start with a little bit of fluid, but we are immediately thinking medication support. Is everybody with me on that? It's so important that shock is not shock is not shock. That we understand the underlying mechanism in acute MI. If we see a patient deteriorating, we're always thinking cardiogenic shock. Cardiogenic shock has specific treatments, and we want to focus on those so that we don't exacerbate the problem.
And again, we've already sort of looked at the blood pressure, and you've already recognized that someone who's hypertensive may be used to higher perfusion pressures. But we generally are very conscientious of any systolic less than 100, and especially when that is sustained for over 30 minutes. So something less than 90, blood pressure less than 90 for over 30 minutes will have huge implications. And remember that shock begins at the microcellular level first, so you're not going to see the blood pressure drop. By the time you see a pressure of 90, that the cells have already been deprived of oxygen and nutrients, and you're already starting to see some cellular death.
And sorry to bug you, and I'm sorry if this is boring because you've heard this before, but some of these things are so important. They're carry around information. A blood pressure less than 70 for 20 minutes or longer is permanent renal damage. Not just saying, okay, blood pressure's around 68, but we're hanging in. No, we're not hanging in, right? We're not hanging in. We need more support. Now, if we're doing everything we can, we're doing everything we can. But until you get to the point, no other ideas, we're not satisfied with that.
And always thinking about shock. So not that we want you to be reading ECGs, but just to put this in the context of a myocardial infarction. So as you can see here, we're looking at ST elevation, and not that it's going to, once you become proficient at reading ECGs, it's of greater than 1 millimeter, and you know how to measure the time. Well, the millimeter is on the other axis, but not that you need to know, but just to see how it is in groupings. As you know, that the 12 lead is a camera looking at all different angles of the heart, and we look at it in groupings. And so as you can see, this is in the anterior lead grouping. So the camera is looking at that particular lead in V2, V3, V4, and V5. It's looking in that area, and you can see ST elevation. And if you saw elevation in one lead, it really you'd be monitoring it, but to be a myocardial infarction, it needs to be in 2 leads that look at the same grouping, or contiguous leads.
Did everyone get that? That to make a determination of an MI, you need to see that ST elevation in more than 1 lead, right? We don't just look at lead 2, or when we look at our strip. As soon as I see something on my strip, I'm doing a 12 lead EKG, because remember, the 12 lead gives us multiple views of all angles of the heart, And that enables us to have confirmation from different angles, and we need to see it in at least 2. The one thing I want to point out that is always interesting, you don't need to know this. I always find AVR interesting, Leslie, because do you see I have those, yeah, do you see those flip T waves in AVR? Do you see up here on the top there, those flip T waves? That's to be expected. So that lead with those flip T waves is to be expected. So you know how we always want our T waves upright in AVR. So that's why when I'm learning, and you're going to learn this in your practice, and hopefully you're going to take courses, when you're learning to read, you need to understand morphology lead by lead.
And what you learn, my personal opinion is AVR is undervalued, and you can get some significant information if you actually look at it, but often it's overlooked. It's one of those poor cousins in diagnostic evaluation, but I think you need to really look at it. But for your purposes, you just look at the ST elevation. And so as we already talked about, medications, you've talked about the important medications already. So aspirin, we're going to give it to the patient to chew 160 milligrams to help, starting with that, the anti-platelet activity of the aspirin. We've also talked about morphine. And again, you've already alluded to the fact that it's multifunctional, that you're giving it to decrease the workload of the heart because it causes vasodilation. It also decreases anxiety, and it will also alleviate pain. So it is multifunctional, although it is contraindicated if the patient is hypotensive, of course, because it causes further vasodilation. And also if the patient, and we're not going to get into all of the particulars and specifics of the pathophysiology of right ventricular dysfunction, but the right ventricle requires a fair bit of fluid in order for it to eject. So if you're having the infarction in the right side of the heart, we would very cautiously give any morphine or nitro. So just to be aware of that. I was always taught that you give morphine until the patient sings. So you're going to watch the blood pressure, but don't just keep giving it to them to help rest the heart. The other drug we've already talked about was nitro, and to alleviate the pain, to initiate that vasodilation of the arteries, both locally so that the heart gets more perfusion as well as systemically. Again, be very cautious. If somebody is hypotensive, we don't want to cause them to be more hypotensive. We actually give a fairly good dose, a hefty dose of nitro with one spray. Although it doesn't seem to be a lot, it is quite a good dose and can cause quite profound hypotension. We also, again, with dealing with the right side of the heart or the inferior portion of the heart, we're very cautious and avoid giving nitro with an inferior MI. Again, moving beyond the scope of this session, but just to tuck that at the back of your mind. Also, the patients who have had erectile dysfunction medications are at risk of having profound intractable hypotension. So if we gave nitro in the presence of Viagra, Cialis, the blood pressure would drop, and it's very unlikely that you would be able to remedy that. So we always ask the patient, did you have a little blue pill? And they'll know what you mean.
Yeah. And I'm just going to add one thing to that. We always think it's only men who take Viagra, but there have been some studies where they were using Viagra with women, not as effective for women as men in terms of sexual function. But so it's really important that we also ask women. And the way I would typically phrase that is, sometimes both men and women can be prescribed Viagra. Is there any chance that you might be taking it? It's so important that we often forget that with women. It's not as certainly about 10 years ago, it was more common that the husband was taking it and the wife was taking it for different outcomes. But anyways, it's
yes. But cautious when you're asking that question. You don't want to do it in front of the family or the wife, because it may be that they are, it might be not with that person or that partner that they are taking the Viagra, maybe with a girlfriend or a boyfriend or another partner. And so we're very cautious when we ask that question. Oxygen, as we've already discussed, the rule of thumb is if the stat's less than 94%, they need oxygen. But as it's been very well alluded to throughout the course, put the oxygen on, check off the airways and breathing. Just put it on until you get the patient sorted out. It's not going to harm the patient. You're right with the patient. So if they, if unbeknownst to you, they were a CO2 retainer, you're with that patient. So you'll recognize that right away. So just get the oxygen on, and you've already done your checklist to prepare for fibrillation medication. And so while you're waiting for cardiology to assess the patient, this is what you see on the screen. And so what is your priority action? So first of all, using a systematic approach, what is your interpretation and what is your priority action?
Now I'm going to say the first thing I'm going to do is find, I want to rate, right, Leslie? I'm just going to start with a rate because we always use our systematic approach. And you see that it's nicely marked here where I've got a QRS that's close enough to being right on the line for me. You see in the middle, there's a little red line above it. I'm going to do my counting because this looks regular to me. Now, again, we're going to take our time, but I'm thinking this is pretty fast. Anybody have any thoughts about what rate we might be at here? The monitor's alarming. Bing, 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 bing. Ashley, you're pretty close. 190. 190 is not bad, but you're a little bit high. We're gonna. Emma says 170. Yeah, you're between, and it's already okay. If you just say so, if you did 300, 150, 100. Sorry, 300, 150. We know it's above 150 and less than 300. And Shelley says 180. Yeah, so somewhere around there, right? Yep, 180, 190, 170, all that. Fine, probably about 180. So any thoughts about that? Bing, 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 bing. Okay, so Jen's saying sinus tach. Consistent ST elevation.
So we've said it's fast. And, is there's another comment here. Atrial tachycardia. And again, I can't really identify rounded upright P waves before each of the QRS. And I suspect they're buried in the T wave of the previous complex because it is so fast, but it is irregular, it is fast, and it is narrow. The sinus may beat around 180, very iffy, but it may. And whoever just, I can't see the chat feature, but whoever just answered atrial tachycardia, you may be correct there. So what do we call that? What is that umbrella term we would use for a very fast, regular, narrow complex with no discernible P waves? What would be the term?
So Nadia's given us in chat SVT, supraventricular tachycardia.
Absolutely, fantastic. So what is, and this is, I'm concerning, I'm going to jump in. I'm concerned because in the presence of myocardial infarction, and now I've got a heart that's beating this fast, I am worried. So what do I need to do next? You could do the Valsalva. what other information do I need? I see that I have a heart rate of 180. What do I need to do to determine if this patient is stable or unstable?
Blood pressure.
I need to know the blood pressure. And so the blood pressure is 88 on 53. The heart rate is 180 and regular. Respiratory rate is 28. O2 sat is 94%. And the patient is now complaining of chest pain.
Yeah, Hannah asked us about level of consciousness. Excellent, because that's often a very subtle indicator, right? Absolutely.
Oh, that is great. And so the patient is responding, but complaining of a lot of chest pain. Jen has asked if we could try the Valsalva maneuver, which is absolutely appropriate. And Jen, how would you do that with this patient? What would you say to her?
I'm assuming she still has adequate level of consciousness, so I would
Yep.
encourage her to, with me, will bear down as if you were having a bowel movement. Try and keep your nose and mouth closed and increase that pressure inside. Okay, let's do this. 1, 2, 3, and we're going to hold it as long as we can.
Yep.
Fantastic, fantastic. And there is no change. What are you thinking? What is the intervention that you'd be anticipating? Okay, so let's just back it up for a minute. Is this patient stable or unstable?
Now remember her blood pressure on arrival was what? Yeah, Ashley's saying unstable. So we're always looking at comparing where someone is from where they were. Yeah, so Molly's telling us she's unstable because we see a heart rate of 180, an increase in chest pain, so symptomology, a blood pressure that's dropping, and she's tachypnic, right? So she's breathing more quickly as a sign. So unstable. Now you guys have algorithms if you printed them off or if you want to go to your screen and pull that up. What are we thinking? Unstable patient with an SVT. Valsalva was a great first step. It's like low risk. While we're getting ready, let's try that. What are we thinking though? Tick, tick, tick.
Would it be too premature?
Are we thinking like a?
Sorry.
Right.
Oh, I would think either medications or because of her BP, maybe even considering synchronized cardioversion.
Fantastic. Excellent. And so you're absolutely correct. We treat, so a couple of things I just want to make a point here. First of all, when you are assessing if the patient is stable or unstable, we look to those hardcore signs to indicate if they're unstable. So that is exactly as you have indicated, that the patient is hypotensive, that the patient has ongoing chest pain, there's an alteration in level of consciousness, that they might have crackles in their chest. So those are all the big signs of the instability. So that's really important. Now, if the patient was nauseated or a bit sweaty, those are things I'm going to monitor for, but those wouldn't be the reason that would determine if this patient is unstable or stable. It's really those big ones: level of consciousness, chest pain, hypotension, and shortness of breath, and crackles in the chest. And so any unstable patient, we treat with the electrical interventions. And those electrical interventions could be synchronized cardioversion, defibrillation, or pacing. So those are the sort of electrical interventions that you would be planning for. Although if the patient was stable, you would be anticipating some kind of a medication. So this patient is unstable, and as I think was Nadia suggested, we're going to move to DC or direct current synchronized cardioversion. And I think it's really helpful for us to refer to it as synchronized cardioversion. And I think we've talked about that too, haven't we? How the use of and so just recall that when you are initiating synchronized cardioversion, that you need to hit the sync button. Otherwise, you're going to defibrillate the patient. And so we need to hit the sync button. And then when consider sedation. It's quite uncomfortable. If you had 60 joule or 100 joules zipping through your chest, it would be quite uncomfortable. So if there is time, we consider sedation, something like a little midazolam or Versed. It's a benzodiazepine given quite nicely, and it also has an amnesic effect. I have given propofol, although that's a bit extreme. We have given propofol. Do you know what they're using a lot of now, Sue? Is ketamine.
I saw that, which actually, so it's interesting to me. I have some reservations in general about ketamine. So I have to open my mind to the use of, to that's use. I've used it in different situations, and I just am a little bit worried. So interesting that they are using ketamine, and I have to look at the data around that.
Yes, they're using a lot of ketamine. And so sedation, if you have time. Now this pressure is a little bit on the lower side. It looks like this patient would be able to tolerate a 1 or 2 milligrams of midazolam to help just relax her while we do the synchronized cardioversion. Some patients' blood pressure is 60. There's no room for the sedation. We just have to get that patient into a perfusing rhythm. So sedation, if there's time, and then we're going to synchronize cardiovert. And I think we've already discussed it. We're going to do about 100 joules to begin with, because as you can see, some cardiovert at 50 to 100, some are at 100. So 100 sort of captures all of those rhythms. So we start at 100 joules and we hold down the shock buttons, whatever type of equipment we've got. We're going to hold it down as it tracks the R wave, because remember, it's going to deliver it on the downslope of the R wave. I don't know if I have yes, I think I've got a demonstration here. So as you can see, this is our monitor, and it's clearly laid out on the monitor. If I could draw your attention to that upper picture where it says 1, 2, 3, that's all we do. We turn it on, we select our energy to 100. We're going to charge our equipment, and then that little shock button in the middle is what we would hold down as we deliver the shock. And I'll just draw your attention to the strip at the bottom where you can see the patient is having a fast rate. The energy is delivered. Somehow my strip got moved and the arrows are in the wrong spot, but you can see that wide QRS, that's where the energy is being delivered, and the patient is now in a sinus rhythm. So the patient is the left-hand side of the strip is in a fast heart rate. The energy, 100 joules, has been delivered where you see that mid-strip, and then you see the patient is now in a perfusing rhythm. So after we've done—
Sorry, Leslie, before you go on, I just want to reiterate what Leslie said. Oh, okay. And Ashley, let's start. We'll answer Ashley's question as well again. But when you are doing synchronized cardioversion, you press and hold the button. So because remember, it has to align at the right point on that in the down stroke of the R wave. And so you press and hold. You don't just like press release, right? You're going to press and hold that because it has to find the point where it's going to deliver that electricity. Is that fair enough, Leslie?
Absolutely.
And then Ashley wanted if we could explain again, whether here or there, beyond the role of the nurse in this situation, in a cardioversion or a defibrillation.
So that's a really good question, because as we've already talked about, that application of energy is outside the role of the RN's practice, although it is part of a nurse practitioner's role and scope. So what happens is at the hospitals, we don't have time to call the doctor and say, I've got a patient in VFib, can I get an order? We need to recognize this. And so we work under medical directives. So as an educator, I certified the doctor, physician group, the interventionist would endorse me or certify me to certify all the nurses. And so we had to maintain meticulous records that I provided packages. Nurses would review the packages on an annual basis, and they would do a hands-on demonstration, and I would actually be able to sign them off that they followed the correct procedure. So that the physician group was delegating that in the emergency situation, the patient doesn't have a pulse, the patient is unresponsive, they have no blood pressure, and the rhythm on the monitor is shockable, that I could apply the energy to defibrillate them. Now, synchronized cardioversion is a bit different because this is more of an elective procedure, and we typically would not perform an elective procedure because you've got time to get the team assembled. Now, I have helped with it, And so I would be working more as an extension of the physician's arms, and they would say, okay, hit the button. But again, I'm responsible. I'm hitting the button. And if I didn't hit the sync button, it's not going to be the doctor that told me to hit the button. It would be under my practice. So definitely it would be a delegated act to defibrillate. Synchronized cardioversion is another matter, and it is an elective procedure.
And Nadia, we want to answer your question. And what else was I going to say? So in our jurisdiction, important to make clear, in our jurisdiction, it's not within your scope, but in other jurisdictions it may. So for example, when I worked in the United States, it was within my scope to be able to do that, and the expectation in the emergency department. Also, oh my gosh, now I'm going to lose my trail of thought. When you're working on a floor, so for example, we say high acuity isn't the name of a unit, it's the kind of patient you're looking after, right? So when you're working on a floor, what might your responsibility be? One of the things I'm going to say that, and I know Leslie, you're going to agree with this, you may be the note taker, you may be the person involved in assisting with things, that we are always clarifying. Do you remember that team steps doc that is so helpful? That when an order is happening, or when somebody is communicating that they're going to do a synchronized cardioversion, that we are always clarifying synchronized cardioversion, right? So we are putting those two words together because that is a change in practice, Leslie. And I think you will find many older healthcare providers, older physicians and other people who are not as careful about indicating that, and that everyone is careful that the sync button is turned on. It is so critical that we're watching that sync.
Exactly. And also too, I think that it's important to know, while this is, we as nurses in certain jurisdictions may not be actually delivering the energy, we set everything up for the person to just come along and hit the button. So we made sure that the airway is being covered off, that somebody is providing, whether it's anesthesia, RT, or the nurse is providing oxygen. You have a bag valve mask available in case this has a negative outcome. We have drugs available should this have a negative outcome. We have all the IVs, we have everything already, so that the person who's responsible just hits the button. But not only that, is that, and they're putting much more emphasis on this too. I don't know if you've realized that they're looking at that July effect of when the new residents all come. So July and January, we all across the world, new residents begin, and they don't know the equipment you have in your hospital. So you're watching them to make sure that they're not doing it incorrectly.
The other thing I want to respond to is, and it is so important, again, that we are support from an entire team, right? So it's not like the new guys are on and don't you know what you're doing. This is a team where we all provide support. The additional thing is, Nadia asked an important question. Does that mean every nurse on a unit would have that responsibility and that delegation? The expectation in a high acuity unit, in an ICU, maybe in a step down unit, certainly in some ERs, although the difference in an ER is you've got a doctor right there all the time. There's never a moment where you don't have a doctor. So it's much more likely you've always got a doctor available to you, unless two codes are happening at the same time. Even so, you've got more than one doctor. So the ICU, you're going to see that the most. But the point in all of this, even when it's all delegated, you've got an order. If you see this, you've got the protocol, you're able to do it. You need to determine that you are capable. So let's say this is the first time you're doing it. Leslie instructed me, I reviewed my package, I did the demo, I have that certification, and there's delegation orders, but I'm still maybe feeling too shaky. I would get somebody in there right that second, if I'm not feeling capable in the moment. Remember, pride has no place in nursing. No place. I am dignified, I am respectful, I am alert, I'm a whole bunch of things. I am pride out, right? So the thing you're always maintaining is that, am I capable? Even if you have the certification, am I capable in this moment? Is that any other thoughts from you, Leslie, who've been involved?
Oh, absolutely. And not every day that when I would be, even with 20, or I'm sure the same with you, 20 or 25 years of experience, There's some days that you just were not on the top of your game. And so I would just say to somebody here, could you take over? I'm going to do the CPR. You do the defibrillation, or I'm going to start the IVs. So absolutely, you would stand back. And so after you've done your synchronized cardioversion, this is what you see again. What are the next steps? Just jump in.
Would you give epinephrine before you apply more energy, or is that if you're doing like a defibrillation? I just want to clear that up.
Yes, and that's a really good question. And so you would only give epinephrine IV push to somebody who had was dead. We would never give IV push epinephrine to someone with a beating heart. And it would definitely, there would be not really an indication right now for epinephrine for this patient. There'd be other drugs that we would be administering. And so I think you said to repeat the cardioversion. Absolutely. So please set up for cardioversion again. And again, you may consider increasing the joules from 100 to 120 or 150 or 200, depending on the type of equipment you have. So you would increase the energy, you would prepare the team, you would let the patient know, and you would, again, deliver that synchronized shock to the patient. And don't forget to reactivate the sync button, because this is first a defibrillator. So as soon as you synchronize cardiovert, that button comes off. So you need to reset it the second time. So you set up for the second synchronized cardioversion, and you see the vitals at the bottom. Blood pressure is now 96 on 55, heart rate is 70, respiratory rate's 24, O2 stats 96%. Fine crackles to bilateral bases, and now you're awaiting cardiology. What are you thinking? So Sue, after you see this sort of thing, maybe you can help us with that piece. They're in your emerge department, and you see this patient's come in with a myocardial infarction and received some TNK, and now has an unstable rhythm. What are your thoughts? Well, maybe Sue's on mute. So really, I want to get to this patient to an area where they can receive appropriate one-to-one care. And I'm not sure the emergency department that they've done the immediate interventions, and now we need to get the patient to an area where they can receive one-to-one nursing care. Nadia is very.
I was on mute. I'm off mute, and I want to say emergency room. Sort of a way of thinking is stabilize, ship them out, right? So we don't do all the fine tuning. It's like if you're a car, we get you to run enough to get you to the right place, but we don't fix the transmission. We don't fix all those things. Stabilize, ship them out. There's too much. I might be get a patient having an MI right in that triage line. So we need to, as Leslie says, get that patient to a place where they have a designated nurse, they have enough staff, they have staff who are intricately involved in this part of their physiology, their heart and the conduction and other things, so that that patient is stable enough for travel just up to a unit. Sometimes they're transferred out depending on other things, depending on how they're presenting, but stabilize, ship them out.
And so thank you for that, Sue. And as Nadia pointed out, I'm so happy to see you picked up on those fine details, that there's a few crackles starting. So are you jumping to get Lasix? No, but you're doing an assessment of what fluid the patient has had, what is the urinary output. This is a patient you may have to put up into semi-Fowlers to improve their oxygenation. And so just be very cognizant and keeping an eye on that. Now, this patient has been stabilized into the CC, or settled into the CCU, received their TNK, and you see this rhythm on the monitor. Why is this rhythm sort of anticipated? I don't know that we actually covered this rhythm with our arrhythmia interpretation, but Just give me what your overall impression is. Is it regular or irregular? What is the rate? And if you recall, we did talk a little bit about this in adult health around that after receiving, so somebody having a myocardial infarction has had an intervention, arrhythmias are quite prevalent, in particular a wide complex idioventricular rhythms are quite prevalent after receiving TNK. As the heart is getting, becoming reperfused, it is having these areas of I guess irritability, and so it's really, and I think I use the analogy is like having a rubber band around your finger. Remember in kindergarten, you wrapped a rubber band around your finger and your finger turned purple. Well, that's like a myocardial infarction. And as you take off that elastic band, you know how you get that sharp pain going up your finger? Well, it's the same thing that happens to the heart as it becomes reperfused. And the patient is also ordered metoprolol. Would you give the patient metoprolol?
No.
No, exactly. And so, but do recall that with myocardial infarction, metoprolol is actually indicated and improves long-term survival. And so we want to just hold off on that metoprolol right now, but know that the patient needs to receive it. So we need to give it as soon as this patient is stable. So the patient is now on 4 liters of oxygen. Vital signs are stabilizing. And there is some bilateral crackles to the basis. Now, do remember, and this is an aside, that bradycardia may be physiologic, as we've talked about in the case of Lance Armstrong. He has a very low heart rate because that's normal. In the presence of a myocardial infarction, it's not, but it is anticipated. What would you do for this patient?
Would you give atropine in that case?
You could in this particular case, the patient is actually stable, and we don't need any kind of medication right now. But I would have the pacemaker right on standby. It is slow right now. The patient's maintaining a blood pressure, but it's having that forethought to think that if this patient should deteriorate, I don't want to waste time trying to find the pacemaker. So the monitor alarms, and you see this rhythm. And so look at the rhythm, and with a systematic approach, what is this rhythm? And I'm going to check and see in the chat feature here. It is not atrial fib, but good try. So the rate is slow. The P waves are upright. It's some kind of a heart block, correct? The ventricular rate is low at 30. There is not a P wave before each of the QRSs, but if you look to see, when you map out those bumps or those P waves, you'll find that they are regular. So the P waves are marching through without any relationship to the QRS. What do we call that rhythm? And in the big scheme of things, it doesn't really matter. It's a bradycardia. The patient's blood pressure is low, so it's a symptomatic bradycardia. And in particular, this is a 3rd-degree heart block. And so, again, the question I'm going to ask you is this patient stable or unstable? Looking at those big, those core symptoms, is this patient stable or unstable? Unstable, absolutely. And so, moving on, what are the priority actions for an unstable bradycardia?
Transcutaneous pacing.
excellent. Transcutaneous pacing. We need to apply some form of electricity or electrical intervention. And so we're going to place the pacer pads. And again, we'll practice this when we get into the lab. We'll definitely set up a mannequin and we'll practice you actually pacing the patient. And so even in the absence of having somebody who's certified in transcutaneous pacing, you're at least going to get the pads on the chest and get it hooked up to the monitor. The other thing that is equally effective to increase the heart rate and the blood pressure is an infusion. So dopamine infusion or an epinephrine infusion. And please make the distinction that epinephrine infusion. So we're giving an epinephrine that's diluted in a solution and we're giving it low dose. So 2 micrograms per minute. So we never would give a IV push epinephrine to a beating heart. And so pacing is often most available. So you're going to start with pacing. But if not, if you're in an area where you don't have the pacemaker, we always have some kind of an emergency cart with dopamine infusing on it. And just to reassure you that you all know how to prime the dopamine, you can prime it. We would just run it through our smart pump. So whatever the pump technology at the hospital, so whether it's Alaris or Abbott or Sigma, we're just going to run the tubing through the pump. And we have parameters on it. So we would just put in the weight of the patient. Sometimes I don't know the weight of the patient. I just looking at our mannequin there, is the patient small, medium, or large, 50, 75, or 100 kilos. And I would add that until I could actually get that I could weigh the patient. Now, most of the beds do weigh the patient, so I can get a more accurate weight after. And that's why a weight is very important to me, because I want to know in case of an emergency, how much of these weight-based drugs I need to infuse. So I would start in a dopamine infusion. I'm going to put that he looks like he's pretty large there. So 75 kilos. And I would start, and there's various ways of approaching this. And we talked about this earlier in the semester. Do we start mid-range of dopamine at 7 mics and titrate back? Or do we start at 2 or 3 micrograms per kilogram per minute and titrate up? We just need to get the blood pressure up. And as we've talked about, you don't want to just jack it right up there to 10 mics and then now the blood pressure is 200. We want to do it so that we end up not titrating and balancing the patients, that we don't want to have those big swings. And so
I think both Jen and I had a question about the not using atropine. Like, why would you just go immediately to pacing and not use atropine?
Not use atropine. So, and if you read on your ACLS cards, atropine, you could consider it. It's not harmful to give it. What is atropine? What kind of a drug is atropine?
I don't remember the class, but I know it increases heart rate.
That's right, absolutely. And that's the important thing. So that's great. So atropine is a vagolytic. It cuts the vagus nerve to allow the sympathetic to take over and increase the heart rate. Remember that you have vagal fibers in the atria of the heart. So in the lower portion of the heart towards the apex, there's no vagal fibers that will be sensitive to atropine. So when you get into a 2nd degree type 2 heart block or a 3rd degree heart block, it's not going to be effective to increase the heart rate. No harm in trying. You're just going to see increased P waves. You're not going to see an increased ventricular response. So atropine is very good for a sinus bradycardia or a AV block type, so a 2nd degree heart block type 1. It's fairly effective for that as well. But as you get lower in the conduction pathway, it won't be effective. So let's just move to something that's going to be effective. But when you're working with a team, and as the certified nurses are getting the pacer on and they say to you, give atropine, it's not going to be harmful, but it's not going to be effective. Does that make sense?
I'm going to just repeat that because I think this is really important to understand. So when we have that vagal innervation, we hear about it in 2 ways. When we do vagal maneuvers, we're doing that to activate that vagal nerve, right? That vagal stimulation. We're doing it to activate it. And when we're using atropine, it's a vagolytic. So we're doing it to deactivate it, right? So that vagal innervation is important. And it's also important to know the physiology. Nurses are always combining physiology. So that vagal innervation, where did Leslie tell you that that is located in the heart? It's not the whole heart, right? So there's not vagal nerves impacting the whole heart. Where in the heart do we see that vagal innervation having an effect? In the atria. So when we have a rhythm where we see a block and we have the P waves going and we have that QRS and they're totally disconnected, what we want to do, the P wave or the depolarization and then subsequent contraction of the atria, or the depolarization subsequent contraction of the ventricles, which gives us cardiac output, ultimate cardiac output? The ventricles, right? It's the ventricles that then pump that blood out. So if we give the atropine, and the problem is not with our atria, so we can get more P waves, but those P waves are not leading to depolarization and conduction of the ventricles. So we'll have the P waves will go much more faster. The atropine will work on those P waves, but the P waves are not leading to the subsequent depolarization and contraction of the ventricles. Those two have become detached from each other, right? Sort of electrically detached from each other. So we need something that's going to work on those ventricles, because that's what's going to give us that cardiac output. Does that make sense? And you can re-listen to this. So that idea of the vagal nerve innervation is important. We use it both to stimulate the vagus nerve response, right? That activation of it. We also use it to stop medications to atropine in particular as that vagolytic to stop that vagus nerve innervation. And what we need to know though is the rhythm, the issue with that cardiac output associated with what's happening where vagus nerve has impact, which is the atria. And in this case, it's not. That atria and ventricles are separated from each other. Whatever we do to the atria, those P waves has no impact on what's happening with the ventricles. Sorry, I don't know if that's helpful or if I've.
That's very helpful. That really helps with that, how this all occurs. So that, very good. Thank you. And so when you prepare a patient for transcutaneous pacing, we place the pads in the same position you would for monitoring the patient, for defibrillation in the patient, as well as for pacing. So below the clavicle to the right of the sternum, and then the apex pad will go over the anterior axillary line to mid-axillary. I put it on the side because people are short in the thorax and you don't want to have it pacing the stomach. So I put it on the side. So anterior to mid-axillary line, fifth intercostal space, placing them and getting really good adherence to the chest wall. So you're going to turn the defibrillator, the monitor, to the pacing mode, and you're going to set the rate. 60 to 80 is acceptable. So let's just turn it right up to 80 and move it along. Then we're going to increase the rate. So you can see this, the rate would be at 80. This is our electrical stimulus, or that is our current, or the milliamps. So we're going to increase that. Now, some monitors have it as a number, and some monitors just have it as a dial. So you're just going to increase it until you see capture. I'm going to show you what the capture would look like. So you're increasing until you see capture, and we always add 10% so that you will have consistent capture, because the heart gets a bit lazy. When you're pacing or any artificial piece of the body gets lazy. If you can do it artificially, it'll let you do it. And so we want to add 10% to make sure it's going to consistently pace this patient. And so this is it. If I can move that slide. Oh gosh, it sort of slipped to the top there. Oh yeah. So this is a bradycardic rhythm, as you can see. And I've got my pacer turned to 20 milliamps, or giving it a little bit of electrical current at about 20. Now, as you can see in these arrows here, that you have these spikes, and this is a pacer spike, indicating that that is going to depolarize that myocardium, but it's not strong enough here because it's not depolarizing the myocardium.
Okay, so everyone sees where those little arrows are? That's called your pacer spike. And what you're watching for is an impact right subsequent to that pacer spike. So here that tells me the pacemaker is working, like I've got some electrical energy that's being conducted, but it's not having an effect. Okay, so it's not malfunctioning, but it's not yet having its effect.
And so as you can see in the bottom, I've turned up my energy or my current to 50 milliamps, and you can see a pacer spike because that's regular at 80, a pacer spike, and it's actually is capturing, as you can see, the wide QRS after that pacer spike. The wide QRS and the T wave is of the opposite direction. So that tells me that I've got a paced rhythm. So I've got capture at 50 milliamps because I've got the pacer spike. I've got a wide QRS because this is coming from the ventricles. I've got a wide QRS. I've got the T wave of the opposite direction. So this is paced, telling me it's paced. And so I'm going to increase that to 60 milliamps just to give me a bit of a buffer so that if this patient's heart becomes a bit lazy, that is not as responsive, then I've got that bit of a buffer. So yes, we've got that pacing spike. So the patient, I've got pacing. All of a sudden, the patient becomes non-responsive. The color is all drained out of the patient. And I go to assess the patient because that's what we do. We assess our patients with every change in their condition. And remember that with these cardiac patients, we always do CAB. So I'm going to check my carotid pulse. And how long do I assess that carotid pulse for when a patient is non-responsive, pale? How long do I assess it for? Ten seconds. You're right. And Shelley said, I hope the patient doesn't die again. The patient hasn't died at all. We've always had a pulse and the patient's always been talking. So the patient hasn't died yet, but certainly, yes, Nadia, you're correct. We check the pulse for no longer than 10 seconds, but at least for 5 seconds, because we could actually be palpating our own. So again, we always go for a carotid pulse and just slip your fingers, just become very skilled at locating the carotid artery. So it's sort of tucked in the sternoclasmoid. You just sort of bring your fingers along the trachea and slip it in. And again, we'll practice this when we're in the lab. And so we're checking for circulation and there is no pulse. What is your priority action? Begin CPR. Thanks, Nadia. And so you're going to begin CPR. What are the criteria for high quality CPR? What are some of the things that you're going to be really concentrating on when you begin CPR?
The rate and the depth.
The rate and the depth.
Glenn said it too.
Yes, thank you. So, and Jen wants you to be on a solid surface for sure. The patient may be on the floor. You can begin on the floor. If they're in their beds, many of the hospital beds have a firm surface. If not, you need to get your cardiac arrest board underneath the patient. And so what depth do you compress to? For an adult?
I think it's 2 inches.
2 inches, correct. So you're going to do it to a depth of 2 inches in an adult. At what rate?
100 beats per minute.
100 beats per minute, 100 to 120 beats per minute. And you're going to allow for recoil. So a couple of pointers here. If you're not doing it at 100 to 120 beats per minute, you might as well not be doing it. If it's less than 100, you're not going to be really affecting cardiac output. And if you're going at 120 or greater, you're not allowing for recoil. And that recoil is really important because as you you sort of let your pressure off for that moment. You're allowing that ventricle to fill, and then when you compress again, you're ejecting it. So you do need to allow for that ventricle to fill, so you're actually circulating blood. So the depth is important, the rate is important, and allowing for recoil is really important. Somebody has asked a maximum of 2 minutes per person. Absolutely. But as we've already talked about, if you didn't eat your breakfast this morning and now you're doing CPR and you're feeling faint after 1 minute, get off the chest and let somebody else do it. Really, really important to have those compressions. And after 2 minutes, you're not effective. I one time had a student say, yeah, I did CPR all the way to St. Mike's Hospital, 45 minutes. And I'm thinking, oh my gosh, after 2 minutes, your CPR compressions are not effective. And we know that. In simulation, the two scenarios sometimes start defibrillation, then CPR does this ever happen? In simulation 2, the scenario sometimes said to start defibrillation, then CPR. So really important. So as soon as this patient is pulseless, you want to begin CPR. And whether you have a defibrillator right there or not, you start CPR. And you actually, the recommendations are now that you charge your defibrillator while the compressor is ongoing. You only stop the CPR for the moment that you discharge and then back on the chest. You don't wait for the doc to say, okay, back on the chest. We don't look at the rhythm. We get back on the chest. The important thing is that we need to shorten up the time we're off the chest to a very narrow percentage. And we now have ways to calculate that, but for our intents and purposes, we need to get on the chest. Emma's suggesting the ratio is 30 to 2. You're absolutely correct. We're going to do 30 compressions, so you need to count out so your person on airway can deliver those 2 quick breaths over 1 second each with the bag valve mask. And that gives you ample time to get an oral airway in situ and to get a good seal. And remember, you're bringing the chin up to in the bag, and you're going to deliver those 2 breaths by about half of the bag. You don't want to cause overinflation. We'll talk about that. And Nadia is asking us a really good question. Is this a shockable rhythm? You're absolutely correct. We don't know. We only know that this patient is pulseless. You've called your cardiac arrest team so that you get a defibrillator there right away.
And oops, Leslie, I'm just going to jump in quickly, and I'm not sure if this is later. 2 things I want everyone to keep again in the front of their mind. You need to be able to put in an oral airway confidently without thinking about it, with comfort in your hand. So when we're all back in the lab, whether you've graduated or not, I want you to come in. I want you to do it over and over and over again until you say, I can do that with my eyes closed, although we don't close our eyes. I want you to be able to put in an oral airway confidently. That is going to make a huge difference in the effectiveness of your being able to bag your patient, right? You don't need to be fumbling around. Secondly, when we're talking about bagging, I don't know if this is going to come later, Leslie, when we're using a bag valve mask, you will see on TV all the time, Grey's Anatomy, wherever, that one person is doing it. Do you ever see that? Just one person holding the making a seal and bagging. What we know from evidence, and we all practice from evidence, right? Evidence that you can get a better seal if you do a 2-person process where one person is holding the mask on the face to make a good, it's very hard. Have any of you actually done this in real life? Has anyone had the opportunity to do that in real life? It is very hard to make a tight seal. You don't realize how hard it is. I always say I have very small hands, and so it's hard to actually hold that seal on with the pressure that you need to have a good seal and bag at the same time. And so we actually recommend 2 people. Yes, okay, and we'll talk to Nadia. 2 people do that. You may not see it in practice, and people will be like, what are you doing? The recommendation is 2. You get we know from evidence, you get a much better seal. Otherwise, when you've got one hand, you can't get it around everything, and you tend to have leakage that's coming out the side. Any thoughts from you, Leslie?
Yes, exactly. And I had been bagging by myself for so many years, and I thought, oh, wow, what is this? And when I actually did a 2-person seal, it was amazing. And that leads into the question that Nadia has. So is an endotracheal tube better? The evidence suggests that we can bag valve mask nicely for the first 20 minutes of a scenario. We can, if we have a good seal, we can bag that patient and maintain that oxygenation for quite a while, because not always do we have an RT available. So we can bag valve mask, and we always insert an oral airway because when a patient's unconscious, everything collapses, the tongue falls back. We always insert an oral airway in an unconscious or unresponsive patient. In a semi-conscious patient, we would insert a nasal pharyngeal airway, but that's the difference. And that was your question, when do we use an oral pharyngeal? Whenever the patient is unresponsive, we would put an oral pharyngeal airway in, and now we're going to bag the patient with the two, create a good seal with two people. And I can do that. And in fact, the old guidelines said, don't even worry about putting in an endotracheal tube. And they have subsequently revised that to say, if you have someone on your team that can intubate, by all means, slip in an advanced airway. An advanced airway would be an endotracheal tube or other kinds of airways. You'll see them on the crash carts. They're called an LMA. They actually occlude the esophagus and the airway, the trachea. So again, they're not any better, but if someone's on the team that can put one in, by all means, there's still strict criteria. They have to have the patient intubated within 30 seconds. So you can't be off the chest for greater than 10 seconds, but if they're trying to intubate, you can give them 30. That is your job as the nurse. Okay, 30 seconds, we have to get back on the chest. So we would stop them, we'd go back to bag valve masking.
And I'm just going to repeat this because, again, this is quite a change in practice. Don't you think, Leslie, over the last, I don't know, maybe even that there was much more focus on getting that ET tube in. And I forget who asked, somebody said, so is putting in an ET tube and being able to put them on a vent, is that more longer term? Partly we buy ourselves time to see what's going to happen. Within the first 20 minutes, I'm going to have some good idea whether we're going to have a successful, whether we've got a shockable rhythm, we bring the patient back, we've got time to stabilize and things are happening, or I'm still working on a lot. What we don't want to do is move to an intervention that might take time away from what we know is priority evidence-based linked to outcomes. And so that's good CPR, application of electricity, and other kinds of things. And we know evidence tells us that if we have a good seal, dependent on a good seal, so you're not compromising on saying we need a two-person seal. It's dependent on good technique. And we've got an oral airway in for sure, and the right size oral airway for adults. You don't have to finesse it, but we've got a good an oral airway in, a good appropriate size, not a child size one. We've got a good seal, and we can bag valve mask effectively for 20 minutes. If there's not somebody on the team who's not going to do something else, like we don't have an RT who's come in who doesn't have another role, don't take someone away from doing something related to rescuing the patient when they could otherwise be doing something else. So it's really important that we don't need to jump to that. We used to see every patient from the field coming in with intubated already, and we don't see that anymore because that process is now, if you can, but if not, just go ahead and have effective use of bag valve masks.
Exactly.
Jen?
All of our training to date for CPR has really been like on the ground emergency, could be applied anywhere CPR. I think maybe 30 seconds in foundations, we discussed how to actually do it in a bed requiring a board or something. Is it common? Do nurses climb on the bed? I guess, does it depend on nurse size, bed level? Because I feel like you don't even have time to sit and go and wait for the bed to go up or down.
Yeah.
So
it is a great question, and I was going to mention that. I have seen many things, right? I've seen many different positions used. It depends on a lot of things. If you're on a stretcher versus if you're on a bed, a stretcher has no room. So I do not, and maybe you've done it differently, Leslie. It's rare that I have seen someone up on a stretcher, kneeling on a stretcher to do compressions. They're on a stool though. You get a stool. I am very short, as we all know, unfortunately, with the sad impact on BMI. But I do compressions from a stool always. I cannot get any effective compression. It's stupid. I would actually tell someone else to do it who's much taller if there's no stool that we can find for a moment. And so that's where I do it. I've seen many people kneel on a bed. I've seen many nurses kneel on a bed because there's much more room on the bed. And also an interesting, and it's good. I'd love to be able to have you again in the lab with the feel of that, right? What does that feel like? When you're kneeling on the bed, it can be uncomfortable because you can be near rails and other things too. So just to be aware of, if you get yourself in an uncomfortable or compromising position, that is not helpful because you are the rescuer. So don't sort of sacrifice yourself, because we may need you for the next 30 minutes to be doing things, right? So don't say, oh my God, I'm hurting my knee, and end up that you can't participate in the rest of the code because you've somehow done something to your knee in the first 2 minutes. I have, the one time I saw a person kneeling on a stretcher actually was when the patient, there was this, I don't know, this bizarre thing that was happening. It was a hospital that I actually, in the United States, was not working at full time. I was called, they transferred some people because there was a nursing strike, long story. So emergency in Washington. And a patient was let out. The patient, they went down, two little nurses, like little nurses, went down to get the patient at the bottom of there was a rampy thing, like a hill down to the bottom. The patient had been dumped. They brought a stretcher, and there was another nurse with them. The three of them put the patient up onto the stretcher, and the two, they were so petite little nurses were pushing the stretcher with the very big nurse up on the stretcher, trying to do compressions. And you could see, honestly, it was like the little train that could, I think I can, as they tried to get up to the top there. To be honest, really, I think they could have run faster with nobody up on that stretcher, or maybe used a petite nurse to do the compressions. I'm not really sure, but you see it much less on a stretcher, but it is a good feel. The other change in practice that we've seen is we always used to say you need a hard board, some kind of like a CPR board or other things under the patient for compressions. And sometimes you still do. Some policy is that you still do, and sometimes it's available. Typically, you'll see it hanging on the side of the crash cart or as part of the crash cart, like a shelf that you pull out. But now many places, I think the evidence is a little bit mixed for this. And so many places that is no longer part of protocol. So when you go to a hospital, one of the things in a good orientation, Leslie, is that they run through a mock code. Every orientation should have a mock code, and you're going to read that, and you're going to pay attention to the nuances that may be different at one organization versus another. And
some beds are firmer.
Evidence, right? What is the evidence? So if they say we don't need a hard board for compressions, what's the evidence? Is there really evidence for that? So, and it seems that we're moving to a place that there may be. So anyways, that's my thing. And when we're in the lab, we're going to try all of that. The awkwardness of it all, the awkwardness of climbing over IV lines that are hanging down to get to be able, in a position to be able to do CPR without pulling out IVs and other things.
Yes. So as we've already talked about, we're going to do our 30 compressions to our 2 ventilations. And remember that when we're bagging the patient, that is not an advanced airway. An advanced airway is only an endotracheal tube or like an LMA. And only when we have a secured airway do we bag the patient asynchronously. So you're going to, when you have an oral airway and a bag valve mask, you're going to deliver the 2 breaths each over 1 second during that short period that the compressor interrupts. So it'll be 30 compressions, stop for 2 seconds, allow the 2 breaths to go in, and then begin the 30 compressions. When you have an endotracheal tube, you just bag once every 6 to 8 seconds. We're going to do the compressions as we've talked about, 2 inches, 5 cycles takes about 2 minutes, but if you're not feeling up to it, then really step back and let somebody else do that, making sure that you're doing good CPR technique. So for me, I see a lot of people that are doing a slap-handed method. Remember, you just want to compress the thorax. So rather than using your whole hand, we recommend that you use sort of the heel of your hand, locking your arms, leveraging your shoulders and body weight over that patient so it doesn't injure your back. And allow for recoil. Very important that you allow for recoil. Change your compressor. And your team leader may not be aware of that or just automatically think that we're changing. So if you see somebody's been on the chest, then you'll say, I'll take over next. And they do this calculation that 60% of CPR should be on the chest. And with all the devices we have nowadays, and they're even recommending that on real codes, they want us to be monitoring to see that we are not interrupting the compressions. So Chris Saxton, as you recall, she became unresponsive. We checked her pulse. There was no pulse. We began our CPR, And finally, the crash cart has arrived and the code leader said, hold CPR and check the rhythm. And this is the rhythm you see. What is this rhythm and what is your intervention? It's ventricular tachycardia. And so what is the intervention? So this is pulseless. We've already determined this patient is pulseless. So pulseless ventricular tachycardia. What is the intervention? It is a shockable rhythm. So thank you for that, Kelly. Is it shockable or non-shockable? This is shockable. And so you're going to prepare to defibrillate this patient. Again, as a skill that you'll learn in clinical or when you're in practice, you may work in an area of high acuity where you will be certified in defibrillation. And so when you are on code duty, we always prepare. And so basically, if you forget, the directions are right on the monitor. 1, 2, 3, turn the monitor on. Select the energy, and in this case, it's defibrillation. So we go to maximum, whatever type of equipment you've got, 300 joules. You need to charge it. CPR is still ongoing. Once I've got it charged, I'm going to say all clear. And doing a visual check around the bedside to make sure nobody is still attached, either your lanyard's not touching the bed or that your team, maybe somebody's trying to intubate and now they're, and so you're going to say all clear and do a visual check to make sure that the team is safe. Then you would hit that shock button, and as you can see, that little red button would be the defibrillation button. So you're going to shock the patient, and then you're going to resume CPR. That's the most important thing, that as soon as you've finished, if your finger comes off the shock button and it's defibrillated, you're going to say, oh, resume CPR. Very important. And we're going to do 2 minutes of CPR. Couple of questions here were around roles. Typically in a cardiac arrest, those roles are very well defined. We have a cardiac arrest team and we have cardiac arrest protocols. So typically the ICU nurses, 1 or 2 are assigned to be the code nurses who would be in charge of defibrillating. The other nurse would be in charge of establishing vascular access or getting the IVs in and preparing the drugs. The RTs would be available. They would come to the code wherever it was announced to provide that airway support. So that might be that they're doing the bag valve mask. You might be assisting them by holding a good seal while they bag. They may be able to intubate the patient, and because that is their role, that they would be moving to earlier intubation. And then you would have the floor nurses available to grab equipment that would be necessary. I need some more normal saline lines. We need some more boluses. We need to send some blood gases. So we would have the floor nurses available as assistants. And we'd also have porters available that if we needed to have equipment brought to us, or if we needed to get some drugs from the pharmacy, we would have porters. And that would be the role of the PSW. It could be backup in portering. Now, some hospitals I know in rural areas, the porters are actually trained in CPR because we train bystanders to do it. So they might be part of the person who's actually going to do the compression. So PSWs would be trained in doing CPR, and certainly depending on the protocol of that hospital, depending on the types of members of the team, the PSW may or may not be doing CPR, but could be definitely providing that portering support. Or also the other role and you think of the students, and I'm going to say, if you see somebody arresting, you get right in there and you get your hands on the patient's chest, because the first time you actually do CPR on a real person it can make it is a little bit different. So you just want to push your way in there and get on the chest so you can say you've done it once. But what you could also be doing is flushing through normal saline, lines with normal saline, priming a couple of liters. And also being with the other patients, they know that there's action on the floor, they've heard the code, And so just being there for the other patients to reassure them that everything is fine, it's under control, they're being cared for even despite an emergency on the floor. So just being available and checking in with all the other patients is a role for the PSWs. Nadia is asking.
Oh, sorry.
Yeah, go ahead.
Before I lose my thought, also a really important member of the team in a hospital that is very patient and family centered, the social worker comes to a code as well, the social worker who's available, and that social worker's first thought is there family that I need to be attending to in this moment? Sometimes you have a nurse who can attend to the family. Let's say a person's partner is with them when this happens. Let's say other things are happening. The social worker is an important addition, in particular in the emergency department. You're going to see that the social worker is going to come immediately to see if we need that person's support, and the social worker will take responsibility for a family member to let them know what's going on, maybe take them to a quiet room, some other place, maybe be with them, and that may take some allocation of both a nurse or a social worker, be with them in the midst of a code when they're there and ask. We know there's good evidence that says families actually cope better following a poor outcome when they've actually witnessed a code taking place, witnessed all those interventions, and see how hard the team works. That actually, we think the potential is that it could be traumatic. And the evidence tells us actually that the potential is they're much more able to heal following the situation when they've seen that everything was done. So not to forget that person.
Absolutely, and that is very critical. Nadia, I love the way you're thinking. And so why would you start at maximum? Because we know that as applying that energy, we do damage myocardial cells. And so the difference between applying the maximum energy in this particular situation is because the patient is dead. We don't have time, like we did when we were doing synchronized cardioversion. We need to zap that heart to depolarize all the myocardium to let the SA node take over. We need to work at it very aggressively, because there is a slide, I didn't put it in this series, but there is a slide that says for each minute that you are unable to get a perfusing rhythm, your chances of improving their patient outcomes diminishes by a half. So by the time you get out to about 6 minutes, 7 minutes of not having a perfusing rhythm, the patient's chances of survival are like 6%. So it's really important that we get on it very aggressively and get this patient into a perfusing rhythm urgently. But I love that thinking, great. And so once we have delivered the energy, we've got the patient, we're getting back on the chest very quickly. And as you can see, we're going to be doing CPR, and we're going to be doing our 30 to 2 until we get the patient intubated. So 2 minutes later, this is your rhythm. We've interrupted compressions because you've already told me we're going to do compressions in cycles of 2 minutes. And so, and I don't know if we've made this point really clear, but as soon as we started CPR, and as soon as you have the defibrillator there, you're going to interrupt compressions to do that early defibrillation. Because the only two things that will make a difference to this patient, to Chris, is that there is early defibrillation to get into a perfusing rhythm and high quality CPR. So we need to interrupt the compressions to defibrillate, and then from that point forward, no interruption. Every 2 minutes only. We wouldn't interrupt it just with willy-nilly. It would be every 2 minutes. We would do an reassessment, and we see that the rhythm had changed from a wide complex tachycardia into this rhythm. And so what is this rhythm, and what are the priorities? So this is ventricular fibrillation, exactly. And so this is, as you can see, this is a erratic rhythm. There's no regularity to it. It's fast, it's irregular. It's just the ventricles are just quivering. There's no pattern to it at all. And so what is our priority with ventricular fibrillation? One of the deadly ones. It is one of the deadly ones when you're correct. So defibrillation is is so important. So defibrillation is going to be the most urgent. And there is intubation. Sure, we can work on that, and we'll talk about that in just a moment. So we're going to proceed with our second shock. And again, I'm setting up the monitor. I'm following the 1, 2, 3. I'm going to charge it to 300 joules. And now I'm going to do a visual around the bed, all clear. And I'm going to hit the shock button, resume CPR. So now I've delivered my second shock. Referring to your cue cards, what is the next thing I do with the ACLS algorithm? What is my next priority after the second shock? Yes, medication is correct, Kayla. Which medication in particular is important to administer after the second shock? Amiodarone. Amiodarone comes a little bit later, Nadia, but you're absolutely correct. We're going to keep, epi. Yes, correct. I didn't see that earlier. Yes, you're going to give epi 1 milligram IV push immediately after that second shock. So that way you have 2 minutes to circulate that drug. And that comes in the pre-filled syringes. And if you've never put one together, we'll show you how to do that. Epinephrine is a very important drug to give after the second shock because it causes massive vasoconstriction in the periphery. So this person's been down now for a minimum of 4 minutes. And so now you're going to, we need to tighten up their periphery and shunt blood back to the important organs, the heart and the brain. It also improves the perfusing pressure to the brain. So just by the mechanism, it's going to, whatever little bit of blood flow there is, it's going to try and get that up to the brain so that we can preserve neurological function. And it also, and for lack of better words, it also causes the myocardial cells to perk up so that they're going to receive a charge better. So it's going to, and I'm not sure what it is, but it just helps the myocardial cells to be more responsive to defibrillation. So, and we give it IV push because this patient is dead and we need to make urgent interventions. And so, but we would never give this to a beating heart. We would never give this to any other rhythm but ventricular fibrillation and ventricular tachycardia and one other rhythm. We'll talk about that in a minute. After the third shock, and again, we time it after the shock. So we've held compressions, we've shocked the patient. We're now resuming compressions. We've got 2 minutes to circulate the drug. We are going to give our third medication, which is amiodarone 300 milligrams IV push as an antiarrhythmic. Now, Sue, do I have a few more minutes here? I think we're just, I'm not sure how long we've got booked, but I want to be cognizant of everyone's time.
Is it okay with everyone if those who have to go just exit, and we'll keep recording, and so whatever you have missed you can catch up on when you come back? And otherwise, we're almost at the end of this. If we can just run through it, I think it's really helpful. Does that work for you guys? Are you finding this? It's not to our best. Okay, thanks. Leslie and I would love to have your hands on, but for the moment, walking our way through all of this, I'm finding it so engaging. It's actually making me just really wish I was there as this was all happening. So
yes, and we haven't even touched upon protected code blues, and I'm not sure if you want to do that, Sue, or if we'll do something special in addition to protected code blues for COVID. So again, once we have done our third defibrillation, we give the amiodarone 300 milligrams. And we're going to continue with our compression. I just want to remind everyone that as a code nurse, we would know that epinephrine is given every 3 to 5 minutes. And so the code team later will say, just start epinephrine after the second shock and continue it every 3 to 5 minutes. So I wouldn't wait for repeating order. I would just, I would be looking at the rhythm and I would be giving it as appropriate.
And also, I'm gonna pipe in here again. Remember that team steps approach, that you're always making sure the entire team knows. And I always like if you're in a room where you're writing on a whiteboard or somewhere public where you're constantly updating epi in other things so that people can see that progression all the time. You can see it, someone else can see it.
But also, Sue, I think that's so critical because when you are in a code, everything is happening, time is warped. Sometimes it really speeds up and sometimes it feels very slow. So that's why it's really important for the code nurse who's giving the medication to say 1 milligram of IV epi given, so that the co-team leader checks that off their mental Rolodex that, yep, that's given. I need to start to think about other things. And also that everybody on the team knows that the epi has just been given. So it's very, very helpful. We need to use that closed loop communication. And also at this point, we're starting to think about what are the 5 H's and 5 T's. And Sue, have you addressed that, the 5 H's and 5 T's? I think you're on, are you on mute?
I'm going to ask you, would you mind going over that a bit? Just this idea of, we start to think, what have I not yet dealt with? So I'm following a basic algorithm, but what is unique to this situation that could be complicating it, that could be leading to what I'm finding, what we're experiencing here?
Yes, absolutely. And even when, right at the outset, very experienced core team leaders are starting to look at the 5 H's and 5 T's. And so as you're thinking about, is this hypovolemia, hypoxemia, hyper or hypokalemia, hypothermia, hypoglycemia, and so any of those 5 T's, and it's very simple. You get it, the IVs in. Let's start giving a bit of a bolus. I've got a good feel. If I really thought that if the team leader thought that it was due to some respiratory issue, then that they would move to getting the patient intubated. And as we're moving down the algorithm and time is ticking, maybe intubation is much more appropriate. We're looking at, if this is a patient that we fished out of Lake Ontario, we need to continue to do compressions until the patient is warm.
And can I just tell a quick story here? I always think stories help, and I feel pressured for time, but I just think this is our last time together, and I might have told this story already. But when we talk about hypothermia, we're not talking about somebody who has a temperature of 35, right? Like, some people run low. My mom never has a temperature above 35.5. That's just the way it goes, right? Like, some people do run a little bit low, but so we don't think of that as extreme hypothermia. We're talking about extreme hypothermia, somebody who's been out in the streets, right? So somebody who's been in cold water, other kinds of things. And one of the premises that we always follow through on in the ER is you're not dead until you're warm and dead, right? You're not dead until you're warm and dead. So if somebody is homeless, it's a freezing cold night, they're brought in and their core temperature is 32 or 31, let's say, we cannot pronounce them. We're doing CPR and they have no, cardiac rhythm, nothing. We're doing CPR sometimes for several hours, sometimes even up to 8 hours, until we're able to warm a patient up to be able to pronounce them. So you're not dead until you're warm and dead. And I'll give you a story that I think really illustrates this. It was at a GTA hospital. It was about, I think, Leslie, 5 years ago. A young girl, 16 years old, told her mom, like, she had terrible abdominal pain, whatever. So it was a freezing cold night, like -30 with the wind chill. The mom and the daughter went out to wait for a bus to go to the hospital to be checked out. And while they were waiting for the bus, the girl, who had not told her mom anything, she was actually in labor and had this baby. So she had her baby right there on the street at -30 degrees. They call an ambulance, like the mom, they call for, and it takes a while for them to get there, whatever. And they bring the daughter and they bring the baby, and the baby is pronounced dead, right? The neonate is pronounced dead. There's no respiratory effort. There's no rhythm. They run a neonatal code, a code blue on the baby, a code pink on the baby. The baby is pronounced dead. Katie, please get that, please. About an hour and a half later, as the police come, so following that kind of death, the police would come, it's going to be a coroner's case, all kinds of things happen. The police walk into the room to get something, not to check on the baby, to get something, and they see the cover on the baby move. The baby has warmed up and was breathing now. The neonate was now breathing an hour and a half later. And then, of course, they call everybody in, and that baby survived. The baby survived. But it is a catastrophe that they did not follow that premise. That neonate needed to be warmed up before you could ever call a code, right? Because of that impact that when we hit that freezing temperature, freezing water, particularly pronounced in children, that our heart rate drops dramatically to the point of being in stasis. Our body is like in stasis, and we're able to recover. That's why we often are able to resuscitate young children who fall in freezing cold water and appear to have drowned for a long period of time, but we're often able to get them out and they're able to recover. So I think an important story that you're not dead until you're warm and dead. When we talk about hypothermia, though, we're not talking about 35 degrees or 30, it's below normal, but that we're not talking about that kind of hypothermia. Sorry.
Thanks, Sue, and that is so important. And so there was a question, is this the etiology or the complication? It is the etiology. It is the cause of this cardiac arrest. We're always trying to uncover what was the cause of this so that we can intervene and change the trajectory of this patient. And so earlier in the code, one of your colleagues has drawn some blood. So as we started the IV, as you start the IV, you have drawn your blood. And so, and there's some requests to repeat it. So there's a 5 H's and 5 T's that you're always trying to uncover with these cardiac arrest patients. So hypovolemia, hypoxia, hyper or hyperkalemia, hypoglycemia, hypothermia. The 5 T's are thrombosis, so that could be a pulmonary embolism or myocardial infarction, tension pneumothorax. So again, if you think about it, that somebody's fractured a rib on a motorcycle accident, and they fractured a rib and that's punctured their lung. And so now that right lung is filling up with air. So with each breath they take, it's filling up with air and pushing pressure onto the heart to the point it's impeding the ability for the heart to actually output. So you've got a pneumothorax, pericardial tamponade. So you've got blood filling up in the pericardial sac, and it's sort of like a wearing spandex. It's that tight constriction. Again, not able to eject. It is what is the other T? Toxin. So it could be a drug overdose, either intentional or unintentional. And so the blood works come back, and somebody's come into the room and handed you the handwritten paper, and these are the lab results that you're provided. And I'll just give you a moment. What is your immediate concern and what is your intervention?
Potassium's really high.
Thank you for that. Yes, jumping on that potassium. What would be your intervention for hyperkalemia in this sort of a situation?
And there's some sort of like calcium gluconate or something.
But yes, absolutely. So again, the potassium is of concern and the acidosis, but in particular that potassium, because I'm trying to get the heart going again. And if the potassium is so high, I'm just going to have more arrhythmias. So my priority in this case is that high potassium. I'm going to deal with the blood gases. My oxygenation is not bad. Or did I not put it in there? Oh yeah, I did, 92%. So my oxygenation is not too bad right now. So I can improve that gas right now, and I'm going to address it. But my potassium, I can. So we do give a cocktail in this situation because this patient is in a critical situation. We're going to give the cocktail of insulin and dextrose. Now, sometimes some hospitals will put in bicarb, but we are very reluctant to use bicarb because once you add that, it's very difficult to correct it once you stabilize and have a perfusing rhythm. So insulin and glucose. Why am I giving insulin?
It binds with the potassium and brings it into the cells, so it's not bloodstream.
Absolutely. It's going to drive the potassium intracellular. So it's removing it from the intravascular, so it's going to drive it intracellular. However, because we're giving insulin, we don't want the patient to become hypoglycemic. And so we give, and I'm sure you've seen those big amps of D50W, we give about 25 mils of D50W. Also, I believe it was Jen mentioned that we're going to give calcium, and we're going to give actually calcium chloride, 1 amp of that, to help stabilize the myocardium. That will buy us about 6 hours, give or take, to help stabilize that myocardium while we try and figure out why this patient has high potassium and how to eliminate it permanently. So potassium is the actual priority.
I'm just going to, Leslie, do you mind? I'm sorry to interrupt.
Yeah, jump in.
So just to remember this cocktail, and this is a short-term cocktail. So if somebody has a high potassium, and then we're dealing, all this is doing is not getting rid of the potassium, it's storing it. It's sort of storing it in a safe place for you, but it's not getting it out of the body. Yes, I see that, Lovey. And so you're giving the insulin for a side effect of the insulin, not for the purpose of insulin, which is to bring down blood sugar. This is not for a diabetic patient. It has nothing to do with that. We're giving it only for the side effect, which is that insulin drives that potassium intracellularly. And when potassium is within the cell, it is safe. Your heart is not going to react to the level of potassium within the cell. It reacts to the extracellular level of potassium. So we give that insulin to drive the potassium inside the cell and bring it down. We also have to counteract the actual effect of that insulin, which is that we'll suddenly and dramatically drop our patient's blood sugar level. So we give that D50W, not just hang a bag of D5. We're giving that syringe, as Leslie says, that it's a big whopping syringe of D50W. It has, I think, does it have 50 mils in it, Leslie? And we give—
It does. We give half of an amp.
Typically about 25 mils of that, right? So typically about half. And then also we sometimes or not, and again, different protocols, give that calcium gluconate. Now, have you seen calcium chloride, Leslie, or just calcium gluconate?
Calcium chloride, calcium gluconate is not as powerful as calcium chloride.
Yeah, that's an important change, because for me, I would the more often deal with protocols with that. So calcium chloride, and we'll correct it. That sort of, imagine it. You don't need to know all the physiology. Imagine that's protecting the heart from getting too excitable, and it's short term. That's a short term protection, but it's sort of helping your heart not to be too excitable within this context for a short period of time. So that buys you a little time. Driving that potassium into the cell buys you a little time, as Leslie says, about 6 hours. But we only have a short period of time. And then if the patient survives, we're going to have to manage that by actually giving medications that are going to take that bind with the potassium and help it to exit from the body. And that's actually that K-exolate, right? Which can be given orally, be given by enema, and that actually removes the potassium from the body. But in an emergent situation, potassium is 6.9, and we've got clear effects of this. We're not, that K-exolate is not going to work quickly enough. If I give something, well, first of all, the person's dead. I can't give them anything orally. I'm not going to give them enemas of K-exolate because they're dead. We need to do this instantaneously, and that insulin works instantaneously. Everybody, I don't know if I've belabored something you already know, but just to understand how and why that cocktail is given, has nothing to do with diabetes. It has everything to do with the side effect of the insulin on potassium, and yet we also have to deal with the major effect of the insulin to protect the patient from it. All right, and it's instantaneous. That's going to drive that potassium into the cell very, very quickly and bring that down. And we're going to have some protection for some period of time. Eventually, we would have to get the potassium out of the body. Okay.
So thanks for that, Sue. You're absolutely correct. And as Nadia has pointed out, troponin is elevated, which is confirming what our initial suspicions were, that this was a myocardial infarction as one of the H's or the T's. If I was unsure with the H's and T's, if it is hypovolemia, GI bleed, or a trauma, I could give a bolus of saline. That will be helping that patient. So we can check off that. Go ahead, Sue. Oh, okay. So you give your bolus of saline, although I'm very cautious of giving it to any kind of a cardiac patient, someone who's suspected of having myocardial infarction. If you really thought this was due to some kind of respiratory issue, then by all means, proceed to intubate this patient earlier than later. This would be somebody that would be considered for earlier intubation. We've recognized that it's definitely related to the potassium, although it could be hypokalemia as well. So perhaps this patient, and we can't bolus potassium, so we need to bring up the potassium slowly, although we do use concentrated preparations, but not in unmonitored areas. But we can replace that. If it is, warm the patient if they're hypothermia. If it is hypoglycemia, we know we could do the AccuCheck and give some glucose as necessary. If you're suspecting it's a pneumothorax, you can actually auscultate the chest as you're delivering the breath, the bag valve mask. As you're doing the two breaths, you could auscultate to see if you have bilateral breath sounds or palpate the trachea. If you would look to see, maybe you need more history and the family is there. Maybe Chris was on some kind of hormone replacement, or especially in younger women, perhaps that they're on birth control and they've thrown up pulmonary embolism. I would look at their calf to see if they have any redness to help me to uncover what is the underlying cause of this cardiac arrest. What other toxins? I'm just going to see. Perhaps if they were inadvertently, maybe they were out at a club and they could have been inadvertently slipped something, or perhaps the lady, Chris took too much of her own metropolol. Maybe inadvertently she thought she was supposed to take 2 and she took more than that. So you look to see what are the other causes. You may need to do a more thorough history. Send somebody out to speak to the family and really do a very good interview or a good detective work to see what other causes this could be. So
before you move on, yeah. Can I just share one thing? Leslie shared with me a couple of years ago, and this one was quite frightening, that one of the trends we were seeing is that students who were feeling so incredibly anxious about exams and feeling, like having tachycardia and other symptoms, there was a trend where they were taking their parents' beta blockers for exams so that they wouldn't feel so nervous, so their heart rate would be maintained and other things, but they were passing out from it and worse. So that idea, everyone always knows when we think of Medicaid or drugs, we think of illicit drugs, but it may not just be illicit drugs, right? So we always need to have that open mind about what could be happening, whether we have a younger patient or an older patient. And I told you this story about a colleague of mine who said to an 84-year-old man who was having a very catastrophic MI, if you were younger, I'd be asking you about drug use, cocaine use, because it was sort of a classic cocaine MI. And the man said, why aren't you asking me? I had a great trading week last week and partied last night. So I think we can't have assumptions about what this patient looks like or who this patient is. We ask all those questions. And when we assume that a person feels stigmatized, we have to be careful that it's not stigma in our own head, right? So we learn to ask those questions, ask them at the dinner table. Do you take any drugs on a regular basis? Do you party at all? Like, just ask those questions in a casual way so that you're not adding to the intensity of something. Do you think, is it possible that your son might be using some party drugs, or so that we're not adding some like scariness to it, whispering or whatever? We always talk to someone privately. Okay, sorry, I'll stop talking.
No, please, that's so helpful. And somebody had mentioned the ABGs are, yes, he does have, I'm sure you've interpreted to an acidosis. And so if these are the ABGs, so I would just ask the compressor, change the compressor, and let's see some really good high quality compressions. So intubation was not going to really correct these gases. It's really going to be better perfusion. Although if we're getting down to the end of running out of options, then by all means intubate the patient, but really it's better compression. So 2 minutes have elapsed, and now you've said stop compressions, and this is what you see on the monitor. What is this rhythm, and what are your interventions? So it is asystole. Now, and you would continue CPR. Just as a caution, do you think this could be a lead that's popped off? Yeah, so I always would check that it was actually that a lead had not popped off their chest. You would also check to make sure that it's not a really fine VF. Typically, I always say if it looks like a duck and it quacks like a duck, it's a duck. It looks like a systole, although to be prudent, we would check to see if it was. How many rounds did this patient go of CP? Oh my God, Nadia, as Sue just mentioned, that we might be doing this for 8 hours, 10 hours. Now, if a patient is hypothermic, we tend to do the first round, initially defibrillate, and then we wait till the patient's warm, but we could go until it's called. And in a child, this might be hours. In someone who's 90 or like Prince Philip at 99, this might only be 20 minutes. And so we'll talk about that in just a moment, but this is, you've checked, this is definitely a systole. What are you going to do for, how are you going to assess this? What is your assessment and what are you going to do? So with any change in rhythm, you need to do your assessment. And so you're going to assess for a carotid pulse, check pulses. Thanks, Shelley, you're absolutely right. And so you're going to check your carotid pulse so that you know this is a pulseless rhythm. In fact, I am not feeling a pulse. So at any rhythm change, you're going to check your pulse in less than 10 seconds, because remember, you can only be off the chest for 10 seconds. So quickly check the pulse and the rhythm at the same time. This is definitely a pulseless asystole. And so what is the intervention? Absolutely. It's a non-shockable rhythm. Thanks, Shelley. That's a great way to look at the non-shockable rhythm. So CPR. What else am I going to do? What else is going to improve the situation? Or any potential of converting? What drugs? What meds? Yeah, Natty, can you give us any suggestions? Happy. Absolutely. So you're going to resume CPR, and you're going to make sure that you have high quality CPR. You're going to change the compressor every 2 minutes. You've got your normal saline infusing. I'm auscultating that I've got breaths being delivered, and that epinephrine 1 milligram every 3 to 5 minutes. And as we've already talked about, we've given the cocktail for the potassium to correct that. And we are going to be continuing with our CPR. And so 25 minutes later, the patient remains asystole. What is it that you would like to, do now? So patient's been down for over 25 minutes. We've gone from a tachycardia, presented initially as a myocardial infarction. We provided an intervention. We gave her TNK. She ended up becoming tachycardic, synchronized cardioverted. Patient sort of stabilized while waiting for cardiology, then became bradycardic. We paced. As a result of pacing, it interfered with the electrical activity, and she ended up going into ventricular tachycardia, deteriorating to ventricular fibrillation, and now she's asystole. What is it that you'd like to do? Team discussion on whether to stop. Would there be a medical directive? So those medical directives should be really discussed when the patient is first admitted, and perhaps with a 56-year-old coming in with a bit of chest pain. If there was no medical directive, then we would be very aggressive in our treatment. But if the patient was 90 or 100 years old, then that might change things somewhat. But we would have that discussion about what would you do if you're at this point. And this is when you would say to your team, does anybody have a suggestion or a recommendation that we could implement that would change the trajectory of this patient's outcomes? So what could we do to initiate? What else could we do to help? What intervention? Is there a medication? What would help change this patient's outcomes? and I'm not suggesting that, that this patient is going to actually get a heartbeat back and just go to the intensive care unit with anoxic brain injury. So we consult the team, and when the team comes to a decision, yeah, I think we should call it, then that would be something that we could entertain. And I think you had your PEA algorithm card with you. And so the code's discontinued. So what is the nursing responsibility? The doc said, yeah, call it, and walks out of the room. They've got to go to the next code in the next room. What's the nursing responsibility? And just shout it out. Don't, just shout it out. Would there be any sort of surgical intervention? Not at this particular point, Nadia. The patient has been down too long. It wouldn't be the first time that I've taken a patient to the cath lab doing CPR. We placed a stent very quickly, and that's enabled the heart to be reperfused. And so we were able to save that person. But this patient's been down for 25 minutes. I don't think that we've sort of run out of that narrow window of time to make a surgical intervention.
So, sorry, just about that. So like, I get that you wouldn't maybe do surgical intervention now because they've been down for a long time, but at any point throughout this entire process, would that have ever been an option?
Yeah, so early on, as we diagnosed this as a myocardial infarction, this might, and it's code STEMI, this patient would be eligible, and all the conditions have to be right there, but this patient could have potentially been taken up to the cath lab and a stent placed. But again, those situations are so few and far between where the cath lab is available. You have the team available. This patient is relatively stable otherwise, that we have a positive diagnosis that this is a STEMI. That I have done that before, where we've been doing CPR and got the patient into the cath lab, but very few and far between. So assess the risks and benefits, family discussion, absolutely. Bring the family into the discussion as well. And so ideally the physician and you would go out and speak to the family that despite our best efforts, the patient has succumbed. And so who could we call for you? Can we call the pastor? Can we bring you into to see the patient? And before I bring the family into see the patient, because don't forget, you're in this situation where you're in an emergency room, there's litter all over the floor from boxes that have dropped, from equipment that's dropped. And so I clean up the room. The patient underneath is looking very mottled looking, and of course there's blood splattered everywhere on a white sheet. So even if it's just a dab of blood, that looks like it's really, so I always make sure that the patient is covered up to their neck and that I expose one of their hands so that the family can actually touch their hands. And I kind of supervise that they don't pull the sheet down unless it's important. If it is important, then I'm going to be there and I'm going to do it slowly and controlled. I'm not going to let them whip the sheet back and find tubes coming out of everything. Now, the patient may be, not in this case, but some cases they are a coroner's case. So I believe it's after every so many deaths in a nursing home, they become a coroner's case, or if somebody dies within a 24 hours, oh, it's the 10th, thank you. It used to be the 8th, but I guess we're getting a little more lax on that. If there's under a certain age dies, if somebody dies with so many hours after surgery, they become a coroner's case. And so the coroner, you leave everything as is until the coroner gives you permission. Most times the coroner will say, just transfer everything to the morgue. And so that means that you're going to take the IV down, leave it in situ, but you're going to take the IV down and you put everything into a bag right beside the patient, wrap it all up and leave it sort of right beside the patient, leave the Foley in, leave everything in, and then you would send that all to the morgue with the patient. You would, as Gwen said, you're going to prepare the body for the visitation, and sometimes they'll have family members that are coming from very far distances. If you have an area that they can stay till the family member arrives, that would be great. Provide the family with a private area so they can make those calls have the social worker or the pastor, the unit chaplain, stay with the family, providing that support, because you have to get, as the nurse, you need to get back to the providing care. You honestly, and Sue, maybe this is not, but you need to prepare for the next patient. You need that bed. There's somebody in that waiting room that's infarcting as you speak. And so we need to prepare this patient for the morgue very dignified, but we also need to be confident you need the bed. And so there might be an area where the patient can be placed until the family come from out of town. And with great reluctance, I would have them go to the morgue, but sometimes we just have no choice. With 500 ICU beds with COVID patients, there's not going to be room to have anybody. So then I would actually ask somebody to go with them to the morgue when the family from out of town. I would get the family. I find put on the tea. Put on a cup of tea for the patients or the families. Just having that warm cup of tea really does help decrease their grief. And just check back with them, making sure that they're doing okay. Not every patient's family are going to respond that way. Not every patient's family are going to be appreciative of your efforts. There's some that are going to be screaming and yelling. Some people may even lash out, and if your safety's at risk, call security in a discreet way, but have them on notice so that you are kept safe. And when making sure that making sure everything is labeled, I always like to get the family to take home all their belongings. So this patient will likely have a purse with her and a wallet and a phone. And so those are the things that I remember after savings that had a pulmonary artery rupture, we got them to the ICU and the patient had lost the lighter because they collapsed in the hallway. So making sure you have all their belongings together, give it to the family and document it, document. And making sure that the labels all are correct. So that typically you would label there's a toe tag, there's an external body tag, there's a valuables tag, making sure they all match, because one time the chart didn't match the patient, the body, the ID, nothing matched. And it was such a fiasco. So making sure everything matches. Making sure they have their dentures in, if they do wear plates or dentures, that they're in situ and that they're documented. Did I forget anything, Sue?
No, I don't think so. One thing I would say, and I know you did this as well, Leslie. So on the floor, when a patient dies, we have a little bit of a longer period of time. We do a post-mortem bath on all of our patients on the floor, right? And that is what I would say is, no matter how busy you are, that is a part of dignity, right? That we do a post-mortem bath. Often when patients pass away, and I don't know if anyone has watched the testimony in the George Floyd trial, it's very compelling in terms of the physiology of his death, Leslie, that was on yesterday. But often patients, when we're running a code and a patient passes away, we see that they'll pass their urine, they'll pass stool, they will ejaculate, other kinds of automatic body responses. If we've been using a bag valve mask, so on the floor, we would do a full post-mortem bath. We would make sure that we are sending, remember that, however you want to think of life, and I don't want to offend anybody, but this is the vessel, the body carried the spirit of that person, however you want to think of it. And we treat it with respect. And if you remember, if the family is not there, we are an extension of that family. Mm-hmm. So we treat it with that kind of loving care that we would anyone in our own family. And it's so important that the dignity we provide to a person once they pass away is the same dignity we provide to a person in their lifetime, right? So we don't let that go. In the emergency department, honestly, we don't have time for a post-mortem bath. We don't have time for that. On the other hand, I would never send a person's body to the morgue with stool sitting under them with just a blue pad over it. If a family was going to come in to visit, I would, as Leslie says, I would pull the sheets up. I would make sure that what they see is none of the technical stuff, if at all possible, right? So none of the, even IV lines can be bothersome for family. I always, as Leslie says, leave a hand out and have a chair beside there should they choose to sit or stand, and always have that hand available. I always wash their face. I always wash their face, and I always am attentive. This is a funny thing. Do you remember that Chris came in and she was sweaty, she was diaphoretic? I always attend to the fact, does the person smell? right? Like it is, death is a hard process sometimes. It's a really hard process. And so I would actually just make sure that that person, you know, your last memory of grandma is not that she has BO after she's dead, after you're trying to see her, right? That is, the more we can minimize the view of trauma, the less that's going to stay with their loved ones, right? So that I always ask when I bring a person in, do you need someone to be with you? And if until I get the social worker or someone or a volunteer, sometimes if you've got a long-term volunteer or a crisis worker, if you've got crisis workers in your department, other people, do they need someone with them for a few minutes? I wouldn't leave someone alone if I hadn't asked that question. I may not have the available time, but I might have to say, I'm going to get someone to be with you. And that may mean we pull a nurse from the minor treatment area where they're suturing. And I know it's not, or they have a twisted ankle. It's not nice to have that clinic running short for 20 minutes while a nurse leaves. But this is the priority, right? That the family member is not, as Leslie says, beside themselves with grief and start pulling out tubes or just doesn't understand. They may have many questions. What was that for? What was that for? Did that hurt? Things like that, right? Or just even if they hadn't been part of the code. This is where I will say a few words about being part of the code. That we know family, I think I talked about this already, we know family do much better if they're able to see what's happening in the code. We don't have a group come in, it's typically one person. On occasion, it can be, let's say, a mother and a son, if the son is there to help the mother. We ask them first if it's a protocol that's available in your emergency department or your ICU. Do they want to be part of that? It is much more prevalent in the ERs than ever before, except COVID has changed all of that. And we know the trauma associated with that. But we don't leave them alone. If a family member is coming in, that means one of your team members is fully assigned to them and is explaining things because that's critical. And can you stand it if I tell you a couple of really quick stories? One is a child death. And I always say that, poor Jen knows these stories. One is a child death that I will never forget because there was this nurse, and I just, in my own mind, and I am very regretful for being young and foolish for so many years. I did not hold her in the highest respect that I should have. I don't know. She was quirky in a quirky way. You know, and I don't know. Oh my God. It's just like, she was just so quirky and like, she reminded, I would say, like, I don't want to say something offensive, but like she would be like, seem like a little bit of a country bumpkin to me. And I was a young, stupid nurse. So when you're young, sometimes you think you're more of a hot shot, but she was, anyways. One night, an infant came in and had passed away from SIDS. And there she was. And the mom, can you imagine? It's inconceivable, right? Isn't it inconceivable? You have a live baby and now your baby is dead. You had a live baby and nothing happened and your baby is dead. And after they completed the code, this nurse brought the mom in and the mom was there. And sometimes, depending on the situation, the moms or the parents are allowed to touch the baby. Sometimes they're not even allowed to touch the body, depending on a whole bunch of things. In this case, the mom was allowed to hold her son. And this nurse sat down with her. And every couple of minutes, and she pulled the curtains, and every couple of minutes you could see this. And can't you see this? It's so visible to me. Like, it's such a lesson. The mom would do this. She would do the, like that. Do you know that look? That look of, as if it was dawning on her over and over. But what? And every time this nurse would just say to her as she held this baby, he's gone. It's sort of like the mom was thinking, oh, but maybe, and this nurse would repeat slowly and gently, he's gone. Until inch by inch it sank in for this mom who couldn't believe her baby was gone. So that idea of how we face that situation is so critical to us. Don't you think, Leslie? None of us, every one of us, feels sick to our stomach at the prospect of having to go and tell family what has happened, right? Every one of us wishes we were not there. I have never been in a situation where I say, okay, I'll go. It's okay with me. I'll go zip out there. You know, what can you expect? He was 89. So there you go. Because this is someone who is loved, right? Even when family are ready. I remember these two old ladies, I'm speaking so like not professionally, but these two old ladies coming in and their friend had died and they were in their 90s. She was like 93. And they just kept saying, it's such a shock And I was thinking, my goodness, she's 93. Like, it can't be that much of a shock, but it's such a shock to them, right? To the shock that it happened in this very moment. And so you've got slides for breaking bad news. A couple of things I'm just going to say here. A story that I'm going to tell. I wasn't going to tell because
Sue, can I excuse myself here? I just have to. So I'm just going to jump off here for what, and I'm sorry to have to cut this short. And I love hearing these stories.
And then we'll go. But Leslie, I want to thank you so much. For those of you who don't know, Leslie actually teaches ACLS. She is remarkable. Quickly before I tell my last story and let them go, your recommendation on when these students should take their ACLS.
Well, I've been actually working with Sunnybrook to say that they're ready to go anytime because they've got their arrhythmia monitoring. And so they know the rhythm. So I'm suggesting anytime soon. If you have any problems at Sunnybrook, let me know. The Heart and Stroke is getting a little firm about certain things, but I would definitely advocate. And I want to say that any of our new grads that have taken it have excelled. I'm not kidding. I wouldn't hesitate because you all know how to study. You've got the pathophysiology, the nursing care. They're golden. So anytime.
Yeah. Thanks, Leslie.
My pleasure. Thank you for inviting me to join. I always love it. I love it. I love it. So thank you. Bye, everyone.
All right. So I'm going to finish up just with this story because I think it really helps to exemplify that we are not in the heads of other members of the team. And this is, I think, one of the most memorable situations that I've experienced in this idea of breaking bad news. And I'm sorry, Shelley said, I know you said about an hour ago, Shelley, I hope our patient doesn't die again. One of the things that we learn in high acuity is that I can't guarantee that I'm going to have even one single shift where someone doesn't die. And so my goal is not towards saying, I hope nobody dies today, because I can't work in high acuity that way. What I can say is I hope somebody doesn't die needlessly. And I hope someone doesn't die in a way that doesn't preserve their dignity or that they don't have a poor death. So they're in pain, they're afraid, all of those other kinds of things. And so that's what I work towards. If I set my goal as nobody's going to die today, I don't have control over all those other things, but I can say, I pray and I work it with every ounce of my being that no one dies needlessly and no one dies in pain, no one dies alone, no one dies afraid, other kinds of things. And that's so important that we reframe that because all of us eventually die. And so if we set our intention so high, I think we will live in a way in practice that we're disappointed and it becomes too hard to deal with because we see it as our failure. So someone's death may not be my failure, it's the failure of their body, right? The ultimate end of their life. I'm going to tell this story and then I'm going to let you go. And we are so over and I am so grateful for your attention. This is, and apologies if you've heard it. Oh my God, stop me if you've heard it. Memorable for me. I was working in the emergency department. It was, I think I was a float nurse. So I was the charge nurse. I was the charge nurse. So I was out near triage, helping the triage nurse. And I saw some people come in like long, beautiful satiny dresses, matching long, beautiful satiny dresses. Young women, does anybody know where we're going with this? Purple, long satiny dresses. And I thought, oh, isn't that funny? I wonder what's going on. Was there something? And anyway, so they came in, but they didn't come to the triage desk. They were sort of walking over and I was in the middle of something for a second. And then a couple of men in tuxedos came in. And then we got the call from the paramedics. They were bringing in a patient, VSA, vital signs absent. That patient was a father of the bride who had been dancing the first dance with his daughter when he had dropped and had a sudden cardiac arrest, and they were doing CPR. And as they're telling me this, I see the bride walking in and the mother of the bride. So remember Leslie said often we try to find a private place for people who may be dealing with something difficult. Every emergency department is going to have a place that you know of as sort of the bad news room or the quiet room. Sometimes people call it a meditation, but you have a place right by where you can take family. And so we opened up the quiet room and showed the family a place where they could be together. As the paramedics brought in the father, he was in his tuxedo, shirt wide open, doing CPR. And we proceeded to run a full and robust code, and the patient passed away. So here you imagine there is the daughter dancing her first dance when her father has a massive cardiac arrest, and the mother of the bride, or the partner, mother of the bride, the spouse of this man. And now it's our job to go and tell them that he's dead. And so the doctor, who is a young doctor who was leading the code, and the physician for the ER that night, said, okay, do you want to come with me? And typically a nurse would go with a physician to share that news, only because the physician, as Leslie says, he has to go, right? And often part of our job is we spend a lot more time learning how to pick up the pieces of things, right? Asking those questions. Do you understand what the doctor said? Do you have any more questions? How do you make funeral arrangements? The doctor doesn't tell them how to make funeral arrangements. And I don't know if all of you know, how do you make funeral arrangements, right? So, so we went and we were walking out, and he was right in front of me, and he was almost at the door. So we were just like, it was just, you know, like it wasn't like he was, something was going on that I was behind. I was just behind him. He was going to go through the door, and he got to the door, and it was just funny. It happened like in a split second. He spun around, and he spun so fast that almost like, you know, his lab coat woofed up a bit, spun around and sped off. Just as he was opening the door. Just as he was opening the door, he spun around and sped off, but enough so that he's gone, I'm there, the door is open enough, and the family is staring at me. Like it's a moment forever still in my mind. That like snapshot moment. And so here in that moment, I have the choice. Do I walk into that room or do I walk out? Because a nurse typically does not convey that news. Even if a patient has passed away in hospital, we've run a code, it's unexpected. We usually tell family, we suggest the patient's had a change in their condition. You might want to come in, something like that. But usually the physician does communicate a death. And there I am standing, but they're standing at me, you know, tears glistening on their faces, wondering what just happened. Did the doctor run back because there's something wrong with their dad and he's going to help? Like what happened? And so I had to walk in that room and look at them and tell them the event, tell them that the patient had died, he had passed away, and that we had done absolutely everything we could, that the most skilled physicians and nurses were in that room. And that what I can tell you anything, I can answer any questions that you may have. And if I don't have the answer, I'm going to get that answer for you. But I was there the whole time. I saw everything that happened. We were part of that. I was part of that resuscitative effort. And anything that could have been done was done. Anything that could have been done was done. I can share that he did not suffer. There was no pain involved. That the people who were at that bedside cared about nothing more than helping your loved one, helping your father, helping your husband, and saving his life. And I think it's not perfect. It doesn't help. It doesn't mean he didn't die. It doesn't take away their pain. If I try to take away their pain, I'm going to fail because it's their pain. It's not my pain, it's their pain. But I can at least give them the buffer of knowing what they don't know, of answering questions that maybe they will have, the most important questions. Do they want to know if he got epi or not? I don't know. If they ask those questions, they can have the answers to those questions, but they're not going to want to know that probably. What they're going to want to know is, did he suffer? Did he say anything? I can say he was unconscious the whole time. They were continuing, you know, they followed, they gave every medication and every, they did every intervention that was at all possible without success. And then people often ask me, and then I would ask, would you like to come in and see him? And then if they say yes, I would say, can you give me a minute? And I would go and prepare, right? I would go and prepare. And we've talked about that. In that emergency department, we had a room that had been built to do like trauma x-rays and things that we didn't really use. So there always was a play, or like a sort of a room within the resuscitation room that we could use as a viewing room. And that was helpful so that families had some privacy and they're not grieving openly when there's 3 other patients in other beds and maybe their family members or other things happening. So hopefully there's an opportunity for you to provide some privacy. If not, you always manage dignity in any way you can, not expecting perfection, right? Not expecting perfection, not expecting forgiveness. Family may be mad at you. Family may be so, if they're alone, if they have a single family member, you may want to say, do you want to wait till your son gets here? Or can I call someone for you? When Leslie mentioned the chaplaincy service, that's always non-denominational. So even though you may have a priest coming in who's a Catholic priest or Lutheran minister or something, it's always non-denominational. The chaplaincy is non-denominational counseling and support. So that's really important. And when we describe it to a family who may not feel religious, it's a measure of support that we I think underutilize. People often ask me in that story, then, was I mad at the doctor? And why would I be mad at him? He obviously was experiencing his own trauma. And when I went to find him later, that was his first question to me, are you mad at me? And I said, why would I be mad at you? And he was visibly upset and saying, you know, I just got married, I don't know, 6 months ago. And it just brought me to that very moment. And I just couldn't do it again. I just I couldn't tell one more family member. It just hit close to home and I couldn't tell one more family member, and I'm sorry. And my only question for him is, do you need me to call another doc in? Do you want to go home? You can go home. Do you want me to call in somebody, your backup? And he said, no, it's better for him to work and whatever. And I, although then kept in the back of my mind, do you need some support? Let's just keep an eye on things, because you can go home anytime. Like, as soon as I've got another doc in here, you can go. We're all allowed to be human, right? We're allowed to be human. We're allowed to cry in the car on the way home. We're allowed to say, I just need a break. We're allowed to do anything we need to within the confines of our regulated practice that doesn't interfere with the care of our patients, to also say, I need to cope and I need to process what I just saw. I can tell you that for my entire career, whenever I worked at a hospital that was actually, for many years, that was close to where my brother and sister-in-law lived. And every time we got a notification that a baby with SIDS was coming in, VSA, I would pray in my heart, and it's a terrible thing to admit, I guess. I would pray in my heart, I hope that's not my nieces or nephew. I pray that's not my nieces or nephew, because they live just a couple blocks away. I think all of us take on the responsibility of being with people in the midst of suffering, but it's important to recognize that we don't take away suffering. All we can hope to do is assuage it, right? So I'm here, I'm available to answer any questions. I'm here to support you. But also, I remember a mom of a baby who died from SIDS wrote a very caustic letter later about some colleagues, and she said that nurse shouldn't have been crying. It was my baby. I deserve to cry. Nobody else should be crying. And that's just her grief, right? It's her grief. So people are allowed to grieve. Another thing, and I know we're going to wrap up, but another thing I want to share in terms of this idea of bad news isn't always the same, right? It's not the same for everybody. Bad news varies so much. And so so we don't judge bad news, right? We don't judge who deserves our compassion or our support. And I'm going to tell this very quick story, and then I'm just going to say goodbye. So I was looking again in the emergency department, and it was one of many times I've had to be involved in removing a child from custody of their parent. And in this case, it was a young mom who was brought in by her CAS worker, already involved with CAS, who had, and I guess the CAS worker had gone to check up and had found that the little toddler, about, I think in recollection, I'd say 18 months to 2 years, right? Had a very badly bruised bum all underneath his diaper. And then the worker had brought the little infant, the baby, the toddler, in to be assessed. And also knowing, so he told the mom, we're going to bring the baby into the hospital to make sure he's okay, but knowing that this child was going to be removed from the mom at the hospital, and that she wouldn't know it, because you don't just say, okay, mom, I'm taking your baby. Would any of you just say, okay, okie dokie, right? Even if we say someone is a bad mom, we're not going to say that, right? Like it's so he said the worker had said we need to have him assessed. Let's go and we'll have him assessed, and I'll come with you and I'll be with you. Meanwhile, the arrangements had been made that the child would be removed from her custody in the emergency department by the social worker attached to pediatrics, and the child would be admitted. And so, and it was her boyfriend. It wasn't she who had assaulted, who had, spanked her child so badly that he was bruised across his entire buttocks. But it was her boyfriend. And her CAS worker at a designated time. So first of all, I think it's the burden of, I don't know that. It's on Netflix. The burden of knowing this is very hard. The burden of knowing, even though I understand it, and of course, this is my responsibility, the burden of knowing they are going to remove the child from her custody, and she doesn't know it, and she's this young mom, and she's trusting us, like she's telling us the truth. She's trusting us because she thinks it's all okay. and she has to cooperate because she wants to keep her child, is hard. It's hard for us sometimes to know something that other people don't know, right? And to still knowing this. In any case, the plan was that the CS worker would take her to do some paperwork or to do something, be outside of the room for a minute, and the social worker would come down to get the little guy. And that happened. And the mom came back and the child was gone, and she had to be informed that he had been removed, so that he would, that they would go through a process now. And the mom at that point, I was not in the room, but you could hear her screaming at the top of her lungs. I thought the bum was okay. I thought it was okay if it was only the bum. I thought it was okay if it was only the bum. So in her mind, like, it's not like she was saying, you told me it was okay. It was this idea, but he spanked him on the bum. He spanked him on the bum. And somehow in her mind, that's, I thought that that was okay. I thought that was okay. And she came out of the room, and she was just like, your parents are your human beings. Beside herself with the shock and the grief and the fury. And she came out of her room, and there's nowhere for her to go. Like, where is she going to go? She's in the emergency department. And there was a big, like those old metal trash cans, like a big full-size metal trash can. And she kicked it. She kicked it so hard that it dented in, almost like a huge dent in. And the unit clerk said, should I call security? And I'm so grateful for the wisdom of a colleague of mine who said, her child was just taken away from her. Let her kick a effing garbage can, right? Because she's not somehow less worthy of grief or compassion than someone else. So we don't judge our patients who are worthy or not of compassion. And that is so critical, right? That regardless of what happened, she is still suffering, and we attend to those who are suffering. And so for me, I think that's just an important lesson, that life is not easy and clear. We're not the police, right? That there's nothing good about this situation. The toddler needed to be taken away, at least until they worked something out, figured something out. Like, safety is the priority. That doesn't mean the mom doesn't love the baby. I would find it hard to believe there's any moms who lose their children who don't really at some level love their children. It doesn't mean that little 2-year-old doesn't desperately want to be with his mom, even if it's bad. It's just all so hard. So I think recognizing that often we are living in the midst of complexity, and that for us, we never add to the problem. I am never part of the problem, right? You don't need my judgment. You don't need my meanness. If I can't help, then I can remove myself from that situation, but you're not part of that. I think you can read the slides. One of the most important things I would say is that we tend to offer things like, in the moment, God will help you, or a really important one that we say is, God never gives us more than we can handle. And there's a really important book, When Bad Things Happen to Good People, written by a rabbi, who says, when you talk to people about that, and this woman tells a story of her child dying and being in like the waiting room, waiting to hear this, and somebody saying that to her, God doesn't give you more than you can handle. And she's saying, is that why my child is dead? I'm so strong. Well, why can't I be weak? And then my child would be alive. Or you're saying it's my fault because I can handle so much that my child is dead. You see how that human mind, right? And we don't have magic to fix suffering in the face of bad news. And so sometimes the very, very best thing you can do is to say you're sorry and shut up. We want to fill the space because we can't stand that emptiness of suffering, the tension of that suffering, and yet it is what it is, right? And so that idea that we have to learn to be ready to see suffering, to try to assuage it if we can, to recognize that suffering is not our own, right? And to be able to be in the midst of it while also recognizing those things in a way that helps to keep us safe, that I am not lost in that vortex of suffering. Does that make sense? Okay, so I don't know, it's not a great way to end, but it's important to recognize those things, that all humans suffer, that we are not responsible for another's suffering or to alleviate their suffering. That is our goal when possible. When not possible, we always try to assuage their suffering. And that we recognize that another's suffering, although it is very painful to watch it, is not our suffering. And so we are able to keep ourselves from being swept into it in a way that will prevent us from being able to practice in settings that are high risk, in settings where we are more likely to see those kinds of situations. Well, on that happy note, this is the last time that we are actually going to be together face to face until all of those IOUs come due. So I've said it many times in this term, but a blessing to have had the experience of teaching all of you and to be with all of you. We are all, I can't tell you how much we talk about how fortunate we are in our program to have such remarkable students, and how proud we are of you, and how confident I personally am of the capacity you have to be really remarkable nurses. And I am very hopeful for the future of our profession as I look at what kinds of remarkable human beings you are and what kinds of incredible professionals you will become. So for those of you who are wrapping up your education this spring, I'm so happy for you. And for those of you who are carrying on a little longer, I'm grateful because I may have an opportunity to see more of you in the fall or in the winter. But for all of you, I hope that this term wraps up well, and that you really have an opportunity for a little bit of a break, a little opportunity to take care of yourselves. And that as you move forward, you can bring some of this fearless nursing with you, that you don't need to be afraid, that you can do what you can do in the moment. And that, oh, thank you, Jen, that you have everything that it takes. No one is perfect. You can never know anything. Leslie and I together, do you see how often together we say to each other, would you do that differently? Do you have any other thoughts? We really want to model that. No single nurse knows everything or can do everything. We will all have our strengths. So work to your strengths, and then also build up where you think you have greater capacities that you can grow into. So really, thank you for everything. It has been, oh, thank you all, but it has been honestly, such a pleasure. I do miss the face-to-face. I miss being right there. I miss some of the surprises we can bring to the classroom, and the opportunity for you to really feel things hands-on. But I promise we're not going to let you down with that, and stay in touch. And we would love to know how things go for you. Shelley. The last thing, and I'll send an announcement out to everybody, the final take home, it'll come out, I think, on Tuesday, first day of exam period. It'll come out, it'll be due at the end of exam period. I had a question, can we have groups of 5 instead of 4? You can't have 6. If you go to up to 6, you need to break it down into 2 3s or a 4 and a 2. But you can for sure go up to a group of 5 if you absolutely have to. It's a case study. You need to tell me, or unfolding case study. The good thing about that is that's what you're going to see on the NCLEX moving forward, more of these unfolding case studies, somewhat like we did today. And I hope you really enjoyed how we did it today, to really see how it unfolds step by step. And then imagine if that happened in 20 minutes, 25 minutes. So yes, Nadia, 1 exam per group, and just put everybody's name on it, and I'll make sure the grade is the same. And I hope it becomes sort of like the test. I hope it becomes a learning experience as much as an evaluative experience for all of you. Okay. Any questions?
Sue,
get in touch. Yep.
I was just wondering if we were going to get our last test marks back.
Oh, yes, you are going to get them. And I'm hoping that by the time I give the test out on Tuesday, I've got them all for you, Hannah. Okay.
Thank you.
Oh, you're welcome. I'm sorry. It just takes a little bit of time, and my kids are home waiting for their 3rd COVID test.
Oh yeah, that's completely understandable. No worries.
Yeah, no, really. You guys, I just, I will say everyone has done well. It was a hard test. Did anyone find it a hard test? Okay. But you're doing, like I was thinking, so if you're saying, oh, I didn't think it was that hard, great, right? And grades are good. That tells you what you know. It tells you what you know, right? And I think that idea of how confident you are in really responding to those questions is helpful. I think helpful for you in building your confidence. So hopefully that will be back by Tuesday when I send out the exam to everybody. Oh, and good. I'm going to send it when I send the.
I had a really quick question before we all go. So I know we briefly covered a couple. Oh, Sorry, go ahead.
No, you finish and then I'll finish.
I was wondering more for like our information, if you could provide us with links for information about heart blocks,
Yep.
because I know we didn't really cover it for the course, but like we did look at examples. If we could just get maybe some other additional resources, because I know a ton of us are going into placement this spring, and like I feel like it would be helpful.
Oh, sure. And I'm trying to think, I will try. I don't want to overpromise. I'd like to record them for you if I can, because I have slides for sure. I always want to block, but then I always find it's just, and there's just really 3 heart blocks. Type 1, well, type 1 doesn't matter. Type 2, 2 types of type 2, and so 4 kinds of heart blocks. Well, type 1 matters. It's all that happens later, what might happen later, that you need to know. Yeah, you'll get them. I've for sure I have PowerPoint for those.
I mean, because I mean, I could always do the research, but like your way of teaching just for me makes all the difference. So. Oh,
thank you. I always think, I don't know, like it's always hard, but like at least in the classroom, I always think, okay, I'm losing somebody. I can see I'm losing somebody. Let's reel it back and start from this point again. Because I think reading strips, I had good teachers and poor teachers. Leslie says the same thing. And so when you have a poor teacher and you're just trying to memorize everything, it's too much to memorize. It's all just like gobbledygook, right? And so it's that idea of how do I understand this and tying it to that physiology and the electrophysiology, and then the consequences and how we built everything towards understanding those consequences. So yeah, I hope this course has been helpful. I'm very happy to be able to teach 2 sections of it next year. I tried to move it to be a required course, and there did not seem to be faculty support to make it a required course, although I think it deserves to be a required, but instead 2 sections, 1 in the fall, 1 in the winter. So that will, I think, give more opportunity for a larger number of students to be able to take it. And I hope that we'll see what demand looks like. Oh, is it shot? Yeah. Anyways, I think what I was gonna say about groups, when I send my announcement out that groups could be up to 5, I will also say for anyone who's not in a group, please coordinate through me and let me know so that we can coordinate forming other groups. Okay, so do it individually, do it as a group. I expect, and there's no way for me to say, oh, this is one rubric and another, but when you're working as a group, I'm going to expect more depth than when you're working as an individual, because it's like 4 people or 2 people. Trust me that I am sophisticated enough to be able to look at the depth of 2 people versus 4 people versus 1 person and get what I'm looking for. All right, but hopefully you've got time and you can work around your exams this way. So any other questions, anything else from you? No, thank you. It has been great. Today was a great day. Leslie is a fantastic teacher, and I told you, I found it so compelling. I wished I was there in the room as all of this was unfolding. So it was great. You guys were smart. In case you're walking away thinking, wow, like that was a long 3 hours. Boy, you were smart today, really smart. So I hope you feel really proud of how you engaged with that. Okay, have a great day.
Thanks for the great semester, Sue.
And yeah, any questions, just keep in touch and let me know.
We'll miss you.
Oh, I'm always here. Trust me, I'm always here.
Okay, well, I might take you up on that. You
I
here
love
if
it.
I have questions.
Yep.
All right, have a good day, Sue.
Thank you, you guys. We're just saying goodbye to everybody, Katie. Okay, I think we're gonna